Good morning. How's everyone doing? Welcome to NaRCAD2023. It's so lovely to see you all. It already feels a bit like a family reunion, which may have negative connotations for some of you. But we love our NaRCAD family. We're so excited to be here, especially just given the very obvious fact that we haven't been together in quite a while, and that in the span of time during which we haven't been together, there are so many new faces, so many people that we've met online. I finally get to see everyone up front, as does Vishal and our whole NaRCAD team. So without further ado, we will move right forward. Our theme this year is Catalysts for Change, Powerful Conversations for Better Care, really focusing on the fact that it's the conversation that's being had between all of you and those of you who are not detailers, just roll with me, but all of you and the clinicians who most need you. So welcome. Myself and Vishal are your fabulous co-hosts for the next 2 days. I'm Bevan Amira. I know most of you. I'm the deputy director here at NaRCAD. I'm coming up on my 9th anniversary here. So obviously I love it. I'm ride or die. I will not be leaving unless I am not around anymore, which is a very dark thing to say in the morning. I apologize. Vishal, over to you.
Good morning, everybody. Hard to beat an intro like that. Let's give it up for Bevan one more time. Good morning, everybody. For those that have not met me and those that I have met and have given hugs to, meeting for the first time in person, I am Vishal Kinkabwala. I've been a training facilitator with NaRCAD for the last 2 years, and I've also been the HIV prevention activities coordinator for the state of Michigan for the last 4 years, and I could not be more excited to be here with you all this week. We're going to have such a fun next 2 days.
All right. So I am seeing lots of lovely people joining us from all across the nation, and I think some Canadians as well as people joining in from at home. And you are pointing to someone. Is there someone from elsewhere? Oh, the Canadians. Yes. Give it up for Canada. You're so much nicer than Bostonians. You really are. But we're going to introduce the rest of the team, and I just want to give a warm welcome to everyone joining in from live stream. So hey everyone, everyone's watching us right now, so we'll give you a nice round of applause for joining us virtually. All right. So our fabulous NaRCAD home team, speaking of a sense of family, really excited to just give you a quick wave from our crew. We have at the helm Dr. Mike Fisher. We also have Jerry Avorn here, celebrity status. Our amazing heart and soul of NaRCAD, Anna Morgan Barsamian, is out on maternity leave, but in case she's listening, hey Anna, give some warmness to you. And of course, the woman behind all of this magic, please stand up, Anshul Gupta. You have all been communicating with her. None of this would be happening without her hard work. We also have amazing support staff from Boston Medical Center here today. We have Tra, Mariah, Sarah, and tomorrow we will have Devin. So please keep an eye out for these wonderful folks as they hold up mics and manage the front desk and all of the things that make things like this seem seamless. So thank you guys for being with us. All right, some housekeeping. So the very first thing you need to know is that we want you to enjoy yourselves. Obviously, we can't make that happen, but as you may have seen when you came in, there are lots of little things to play with. On top of that, we want to say, yes, this is a conference, but if you need to answer an email, you're not allowed to. But if you need to answer an email, if you need to step out and make a call, please just take care of yourselves. We know that one thing about being back in person is you're not at home. You can't shut your camera off or go like this and just hope no one sees you. So if you need to move your legs, if you need to move your arms, if you need to go get some more bacon, whatever you need to do, please take care of that. And of course, get your swag on. If you have not gotten your detailing action figure sets yet, please go out front and get them. We really just wanted you guys to have some fun this year. We have fidget kits, or what they call survival kits. And, you can play with those. If there's some left over, bring them home to your friends and kids. And of course, we have sugar. So if you haven't gotten your evidence M&Ms yet, please go get them. And we will have more tomorrow for you to take home to friends. All right, so your program book, this gorgeous handheld, which is so exciting to have it in 3D, Delight was also completely designed by Anshul, and you will find everything you need to know in there. We do have one little typo, which is on the breakouts for the day. We have rooms have changed for one session. The correct information will be up on the screen right before you go to breakout, so do not fear. And 2 of the breakout rooms are this room and the room where you had breakfast, so you probably won't get lost. If you feel like whatever tweeting is called now, Xing, I don't know. But if you feel like tweeting, we would love that. Recommending you use hashtag NaRCAD2023. If you want to type out hashtag academic detailing, please go for it. And our handle here at NaRCAD is just @NaRCAD. But of course, to do that, you got to have some Wi-Fi access. For those of you who aren't staying at the hotel and aren't connected, this is going to be a little tricky because Fairmont has quite a few different networks, but you'll find the one that's just Fairmont, not Fairmont Meeting, not Fairmont Public. You're going to scroll down and enter a passcode, and it's just Copley for the lovely Copley Square in which you are all staying and or here today. So while you're getting settled in with the Wi-Fi, we have a little map here. It's also in your program book. I would say it's hard to get lost here, but I managed to get lost pretty much everywhere. So you'll have your map here. These are the 4 main rooms you're going to be in. This is the Oval. The Venetian is the place where you had breakfast. There is the St. James room, where we will be having a reception tonight from 5 to 6. We hope you'll all join us for some snackies and some drinks. And then, excuse me, there is the Copley room where one of the other breakouts will be. If you need help, the Fairmont staff is amazing. I'm going to turn it over to Vishal to walk us through where you can get the post-conference scoop and every single slide deck, every piece of material, and this video recording for just, I'm sure you want to go home and just watch it all again. So.
Thank you, Bevan. Exactly. Missing NaRCAD after this, really want to get your scoop? Well, we got just the solution for you. If you log on to our wonderful website, which is just narcad.org, you go to the Conference Hub section under Events, and essentially you will have, as Bevan said, all of these slide decks. You'll have all the video recordings, as well as access to our handy dandy program book in a virtual PDF format. If you want to check out stuff that's happened in years before, whether it's our virtual conferences or our in-person archive, check those out as well. We've had such a great history of amazing speakers, amazing sessions, and really just a place to go in there, kind of get back into the atmosphere, really enjoy the vibe that we have going here today, and really getting your detailing on.
Get your detail on. Yes, here is how we are going to go through today. The first half of today, we are kicking off now at, just in a few moments, you'll hear from Mike Fisher. At 9:45, we have a special presentation called The Hero's Journey. It is all about the detailer, what they go through, and how we can best support all of you and have you support one another. We'll have a morning break, and all of the breaks will be right there in the Venetian room for more coffee, more water, whatever you need. We will have field presentations at 11 on highly stigmatized topics. And then we'll have a breathable lunch of 75 minutes at 12:30. Vishal, what comes after that?
All right, once we get back from lunch, we're going to have our breakout sessions, harnessing the power of persuasive communications, where that's when you're going to be able to go into the different rooms and really get some great interactive one-on-one time. We're then going to go into a nice 15-minute break, restock on your coffee, some water, some great conversations and networking. We will then come back in for our afternoon plenary, which is gaining traction, the rise of AD for harm reduction. Going to be having some wonderful conversations. We will then come back, have some wrap up and evaluations. And then I think the thing I'm most excited for is we're going to be meeting for that evening reception. The gang is back. It's always sunny in Boston. The gang will be back. We'll be getting together and really enjoying some time.
Thanks, Vishal. When we have this slide up, this is going to be the slide for Q&A. All of you at home, we are going to weave in your questions as best we can. This is our first time attempting hybrid, so for everyone, both here and at home, please do at the end of both days, tell us how it went and what we can do to make it sharper for next year. For those of you here, throw your hand on up. For those of you at home, you can always type your questions into the Zoom chat box, and Anshul will be going through that, answering what she can via text, and then we will do what we can up here. So we're going to do Poll Everywhere. It's a way for us to take some responses from the folks at home and integrate them with folks here. So please do get out your cell phones so that we can have as many screens happening at once. And we are going to try this out. So you're going to act like you're sending a brand new text message to someone. And you are going to text, instead of the name of the person, it's going to be NaRCAD2023. And you will text the number 37607. And you should see a screen response that looks like, where did it go? Anshul, it's not coming up, so I'm not sure what to do. Give me 1 second here, guys. Okay, let me try this. Sorry, guys. All right, so the screen that tells you the numbers, again, is not up here for visual learners. So I will say it one more time. You are going to text the number 37. You text 237607 with the word NaRCAD 1108. Thank you, guys. All right. Oh, and you can see that at the tippity top. All right, so people are coming in or flew in here in Boston from a whole slew of places: Toronto, Seattle, Mississippi, St. Louis, Chicago, Denver. So keep those coming in so we can make sure this all works.
I think I noticed the Saskatoon as well.
Saskatoon. All right, keep it going. And now we're going to ask the folks at home, where are you tuning in from? So let's get those coming in. We have North Dakota, North Carolina, Eugene, Oregon. Let's get a few more. We have Chicago folks at home. Where's the Chicago crew here? Where's the UIC crew? All right.
Bear down.
We got Brooklyn. We have Cambridge, Maryland. All right, so we're getting a really good cross section here. So now get ready for the third one, where everyone is going to respond both at home and here. Everyone, if you could click your heels and be somewhere else in the world right now. I know you want to be here, so get this right. Where would you like to be? If you had one place you could go, where would you like to be? I don't think the West Virginia person really means that. Sorry, West Virginia, we love you. All right, here we go. Hawaii, Paris. Oh, thanks, guys. Boston, Bali. Yes. Let's get a couple more. The Cayman Islands. Indeed. Bali. Again, we got 2 for Bali. Let's get a couple more up
going
here.
On vacation next up.
What's that?
So it looks like we know where we're going to be going on.
We know where we're going on our first NaRCAD International Conference, Arizona. All right. And Greece, Costa Rica, all good stuff. So now we know this works. Thank you guys for that. All right, so let's move on forward. It is 9:30. You are here in autumn, which is a nice time to be here. Luckily, it's not raining, or I wouldn't have known what to do with this slide. But again, if you've had time to check out Boston, or you want to go out tonight and you need recommendations, come see the home team. We know all the best places to eat everything. And there are folks who have been here many times. So if you want to enjoy Boston, we really encourage you. And now, without further ado, I would like to invite our mighty boss, Mike Fisher, up here. He is truly the loveliest human. We are so lucky to have him at the helm, and he is going to chat with you about why we are so proud of all of you, the ways in which you've grown over time, and what we are just so happy to be celebrating with all of you here at NaRCAD 2023. So Mike, come on up.
All righty. Well, thank you. Thank you, Bevan, for the kind intro. And it really is a pleasure to see everyone here in person. I just can't tell you how energizing it is to be back together. I appreciate the energy that Bevan and Vishal have brought to this, but especially the commitment that all of you have shown. Our local partners, our regional, national, even international. Again, our Canadian partners, but just before I got up from the table, Anshul told me that one of our longtime colleagues from Australia chimed in on the Zoom to say good morning or good evening, or I don't know if there's a word for what time of day it is in Australia right now, but Deb, we're delighted that you've joined us, and it really does emphasize how this has become an international event. I'm going to really do my best to successfully transition back to speaking to all of you in person. Over the last 3 years of virtual conferences, I've gotten used to having a little Zoom pop-up box where Bevan gives me cues to say you're not looking directly at the camera, or no more dad jokes, or whatever it might be. And so I'm gonna really do my best to fly without a net here and see how that goes, and hope we can make it all work together. So let me tell you a little about the journey of this conference series, because we are now back to being together. Jerry and I got NaRCAD started 13 years ago this fall. We got the initial grant. We started doing a few different things. We created training curricula. We began to provide technical support to a range of organizations. And over time, we realized that there was a community developing, and that the community would need a space to connect. We would get on the phone with, this was before Zoom, and people use telephones to speak to each other for any of our more junior colleagues. We would get on the phone with organizations, and as they would talk about what they were working on, we'd say, "Oh, we heard about so-and-so in another state, in another region, who's trying something similar." And we realized that it was helpful for us to tell folks about other people's work or innovations, but it wasn't as effective as putting them together with each other, as really trying to create a community that built off of what we were doing, but was not entirely reliant on us. So after we had back in 2012, we had a one-day sort of pilot planning meeting to sort of get things started. We were able to get our first conference grant from AHRQ, and I think a couple of our AHRQ colleagues were going to be joining us virtually. So just to acknowledge, we are tremendously appreciative of that support for getting the conference series going and continuing that. So we launched that. And then as we walked through it, as you sort of see, from 2013, we launched the conference. Over those first couple of years, we started getting people together. And one of the things that grew out of the conference was in 2015, we started going out and doing trainings on the road. We'd met people at our first couple of conferences who said, "These trainings you do are cool. We like coming to see you in Boston, but we can't do that all the time." And so we started going out. Our first on-the-road training was in California. And since then, over the coming years, we went to dozens of states. In 2016, we renewed the conference grant, and it continued to develop. And by 2018, which you see there as sort of things started to go up steeply, we were getting out, I think, out of Boston, I think almost every month. I think we had 13 or 14 trainings in different places around the country that year. Sometimes actually even in back-to-back weeks. And that was exciting, that was stimulating, and that really built community. And then, of course, in 2020, everything changed. And we've actually, in our virtual sessions over the last couple of years, talked a lot about how the pandemic changed things for us. You know, last year we started to think more about how we change back. And I'm actually not going to talk as much about that right now, but want to talk more about how we have changed as a community over time. That's brought us now to 2023, where, again, this is, we're now on our fourth conference grant from AHRQ, which we are tremendously appreciative of. We've had a long-standing relationship. When Jerry and I got the first conference grant going, a lot of it grew out of work that under Jerry's leadership had been done with Alosa Health, who's the very large detailing nonprofit that Jerry started, who are co-sponsoring this year's conference, for which we're incredibly grateful. And it really is that ongoing sense of community that makes a difference. So what was it like 10 years ago? You know, we had Jerry and I put together this conference with a terrific team, you know, that's turned over since then. As Bevan says, she's been here not quite 10 years. We were definitely very nervous about whether anyone would come. Is having a conference a good idea? We had a lot of speakers talking about general themes. You know, it was a lot of sort of Jerry and I and some people we had curated talking to the audience about what this might be, maybe research topics, how you improve the quality of care and where academic detailing can fit into that, trying to basically push out an understanding of what it was all about. This was the poster for the first conference. So we we used a little bit of a maze analogy. I don't think the maze was made out of Lego, but there are at least hopefully some through lines, and that was really where we were starting from, you know, it was a model where we were kind of at the center and we were working outwards towards everybody else. We were doing our best to listen and to learn, but, you know, we were setting the plan and the agenda for those first few conferences and trying to figure out who the community was and how we could bring them together. I think when I reflect back on where we are 10 years, or I guess 10 years minus 1 day later, if you look back, it was November 7th and 8th in 2013. And so tomorrow will be literally the 10th anniversary. You know, where do we stand? How has our field developed? And how does what we see at this conference reflect that development? I think the biggest thing I would emphasize is the way that all of you who are here, both with us in person and joining online, have built this as a field, as not just a technique, but truly a community and a field of inquiry that's robust, that's connected, and that has been growing over the years, even in these challenging last few years. We've seen broader range of themes in terms of how we improve outcomes, what outcomes we look at, what approaches we take, and how we engage with clinicians and others. And it's really the creativity and the collaboration that makes a difference, that it's become a conversation with all of us, that we at NaRCAD aren't just pushing out to you, but we're having a give and take of what the field looks like. And when it really works well, we even get to be bystanders and see the conversations among you. And that's what's really exciting for us. That wider vision of academic detailing reflects what the community needs. You know, our initial emphasis was on academic detailing as a tool that delivered the principles of evidence-based medicine. And that is critical. The evidence underlies all of what we do. It's the reason that all those M&Ms you're going to enjoy when it's late enough in the day to start eating M&Ms. I mean, it may be late enough in the day to eat M&Ms, depending on your views of candy at 9 in the morning. But whenever you start eating the M&Ms, there's a reason they say evidence is evidence. The evidence is at the center of what we do. But, we've learned from the community how academic detailing can be more than a tool, how it's a service. And really and that was actually in Jerry's original papers, the idea that academic detailing is a service. It's not just the sort of passive receipt of ideas. But I think there's been more of a recognition of the ways in which it is a human service, that the power of the connections between people is what really makes it potent. And that's how it's become a community. So that's some of what you'll see in the conference's development, that it has gone from, I like to think of it as community engaged, where we were trying to sort of draw all of you in, to community centered, where, over recent years, we've really tried to figure out what does everyone in the community need and how can we center around that, to community driven, where we're listening to all of you and you're telling us, where do we need to go? What support do we need to be more effective? How do we make the changes that can really make all of us more effective at providing the kind of support for clinicians and clinical systems that we want to provide, and creating the kind of changes in the processes of care and ultimately outcomes for patients, for all the people out there who can benefit from getting better care. And so you can see, I got so excited I forgot to click to show how cool our snazzy new program is. We have puzzles as opposed to mazes, but I think there's still that sense of engagement and maybe having a little bit of fun in solving puzzles together. So that community-driven approach is reflected in the creativity and adaptability that we see, the recognition of the importance of context across many domains for how academic detailing can make things better for clinicians and patients. And there are a lot of things that we're going to see over the rest of today, over tomorrow, and hopefully in the continuing conversations that you'll be having with each other that reflect where we've been going as a field. So, for example, after I'm done, getting us warmed up, we're going to dive right into content with some of our colleagues from the VA, talking about burnout and morale and how do we sustain academic detailing as a career, as an activity. Thinking about how harm reduction has become such an important part of the many ongoing detailing efforts around substance use disorders, how academic detailing is applied in diverse settings, thinking about the many different populations that can benefit when academic detailing is done well, and seeing it applied to other potential targets, to policymakers, to emergency medical services, to even those who we don't traditionally think of as medical personnel, but who might, with the right information, be able to make a difference. All of this comes back to remembering why we're doing this. In a lot of ways, I think the three questions on this slide that I think of as some of our underlying motivations might not be that different from what we would have asked in 2013 if you'd said, what are we asking? What are we trying to do here? But the way we approach them has changed and deepened as we've built this community. In thinking about how to deliver information, all of you as a community have really pushed us to keep asking, to whom should we be delivering the information? Who can deliver it and who can be most effective in doing it? What's the context in which it's received? What are the other factors in the environment in which it's provided? Some of those questions came in some of those earliest work on AD, going back to some of Jerry's original studies, but they're still relevant in the ways in which we answer them now continue to change. When we think about how we're doing a job, we've been encouraged by all of you in the community to think more broadly about what are the outcomes at the patient level, at the clinician level, at the system level, at the community level that we need to be assessing to understand how we're doing and how we can do even better. Recognizing the complexity of the environments in which we work lets us think about how to be more effective. And that's why the last question is so central. The broader community has brought forward innovative ideas, and some of those have become part of our regular trainings, part of our support, and some generate new ideas that show us where the field can go, what our 21st conference 10 more years from now is going to look like. So over time, we're going to continue to count on all of you to help us set the agenda for where we go. And it goes back to what we said about it being really about the human tool, about it being a social strategy. Even when we had to do everything virtually, we were teaching people virtually how to make human connections, how to get to that other person and help them provide better care to make more of a difference. And that is why all of you are so critical to figuring out how we can do this sustainably. Can we respond to burnout in a meaningful way, as we'll talk about in just a minute? Can we sustain our work to prevent burnout among ourselves, but also among the clinicians and the communities we serve, to continue to make a positive difference? So some of what we're going to talk about as I hand it back over to Bevan to introduce our first formal presentation is thinking about this detailing community and how detailers' needs matters to make us all more effective in serving clinicians, communities, and patients. We have to think about all of us as humans. How do we do this effectively? What are our skills? What are our capacities? And what are our limits? What are our individual needs, and how do we connect with communities so that we can be sustainable over time and reinvigorate the work that we do? So up next, I'm going to hand back over to hear about the hero's journey. But what I'm really looking forward to, in addition to these outstanding presentations, is to that continued conversation, to hearing from all of you about what it's like to be back together, or for those of you online, what you're hearing over your video screens, and for you to keep the conversation going with us and among yourselves about where we all can go as a community to continue growing, making a difference, and learning together. So again, just thank you so much for being here. I can't tell you how exciting and energizing it is to look around the room, and actually even more so stepping into the breakfast room and just hearing the hubbub of conversation that meant that people were reconnecting with each other, seeing the number of just beaming smiles as people hugged each other, seeing for the first time in years, or for the first time in person ever, was really exciting. So thank you for that opportunity. And I'm excited now to hand it back over to Bevan and Vishal to get us kicked off.
All right, so folks at home, we're going to ask you to pop on over to the chat box. And those of you who are hopefully caffeinated enough, I want to pose a question to you where you give us a one-word answer. So be prepared to throw your hand up if you're okay and comfy with our fabulous team running over Oprah audience style to get a word out of you. But please fill in this blank. Burnout feels like blank. Think about that for a second. You can talk amongst yourselves, but burnout feels like. And those of you at home, please join us. I'm seeing the chat box blow up. Lisa Sagwitz, so good to see you joining us remotely. I'm hearing empty, dispirited, dread, heavy, exhausted, apathy. What about folks here? Throw your hand up. What does burnout feel like?
Anxiety.
Anxiety. Yep. What else? Let's get a couple more from our crew here just to kind of shake and wake us up. I know you all know the answer to this, right? There's no right or wrong answer. What does burnout feel like?
Paralyzed.
Yeah, Christine. A wet blanket? Yes, a wet blanket. I heard the word paralyzed. Couple more from online. Gwendolyn Hook says disconnected, disassociation, and let's get one more up here. Adrian.
Sleepy.
Sleepy. Yeah, burnout feels sleepy. Well, luckily for you all, this next presentation will be anything but sleepy. I am so excited to introduce a duo of fabulous folks from the Veterans Health Administration. We are going to have Mark Bonthvang, who is the National Clinical Program Manager at the VHA, talk a bit about a study on burnout assessment from pharmacist academic detailers, give us a sense of the landscape, and right before we feel doomy and gloomy and like we want to hide under a wet blanket or one of those lovely weighted blankets that I enjoy, we are going to hear from Sarah Popish about the things that we can do and the things that she's done with her team to try and address these things. So I want to just say thank you for you both being here. You've been coming to our conferences both in person and virtually for quite a few years. So Mark, he's a fabulous guy, absolute data whiz. He's also an associate professor of clinical pharmacy, and he's just so sharp, and we're so lucky to have some thoughts and reflections from him today and such juicy data that only the VHA can provide. So without further ado, Mark, come on up and walk us through burnout. Thanks, guys.
Good morning. Can everyone hear me all right? Great. What better way to start the day by talking about burnout? So just before I start, some disclosure statement from the VA. Basically what it says that if I say anything wrong or that will misrepresent the VA, they would disavow me, which is, it's always good to know the government has your back. All right. So before I dive into the presentation, I'm kind of curious. I don't have a poll or anything sophisticated like that. But how many of us have ever sat down and quietly thought to ourselves, I'm burning out today, or I've burned out in the last week or so? Okay. Pretty much almost everyone in this room. And how much has that been exacerbated by things like the pandemic? A lot of people. So I just kind of wanted to provide that sort of self-reflection, because when I started pursuing this line of thinking, it really came from my director, Melissa Christopher. As many of you know, she's the genesis and also our leader when it comes to the VA and academic detailing. But she was curious about retention at the VA, especially among academic detailers. This is something that we often don't really think about, especially when we're trying to implement a program at the VA, something as large as a national program. But as we started to settle down into the sustainment phase of the VA, this question became a serious problem. We train a lot of our academic detailers with the skills necessary to be successful at their jobs. And yet we were concerned that these same skills may be the same skills that other people would pursue in order to get them to work for their companies.
Say sorry about the old New England heaters making a rickety racket. Just something extra special for you all to enjoy the true New England experience. All right, back to you, Mark.
Thanks. There's a lot of new things I've learned about Boston today. Heaters. So what we found was that previous studies have highlighted the prevalence of high levels of burnout among pharmacists. Now, I want to preface this by saying at the VA, when we rolled out academic detailing, we used the pharmacist as our main healthcare professional to deliver academic detailing to our clinicians. So we were concerned about the baseline level of burnout among our pharmacists, something we haven't done at all. We know that academic detailing can add another layer of stress, especially to the pharmacists at the VA. For those of you who are uninitiated at the VA, you know the VA requires pharmacists to do a lot of things. How many people here are from the VA? Can you raise your hand? Yeah. And I know that you who work at the VA have done many different things other than academic detailing. Is that right? We fill prescriptions, we process orders, we deal with customer service, we deal with angry clients, and we also have to do academic detailing, as well as run our clinics, get reassigned to different parts of the VA because of the pandemic. I know many of us have been reassigned, and yet we have to maintain some level of academic detailing as part of our profession. Now, pharmacists are allowed to have a clinical practice at the VA. For many of you who don't know, pharmacists can act as a caregiver to patients. And a lot of pharmacists have these dual roles as a clinician as well as an academic detailer. So it compounds the amount of stress that they encounter or experience. So this was the premise for why we wanted to do this burnout survey. Now, this was approved as a quality improvement study, not an actual research project. And this is fitting for what we're trying to do. We wanted to learn more about the job satisfaction of our academic detailers, as well as learn about how we can retain this staff that are really sought after. And once we learned all of these baseline information. We're trying to figure out whether or not we can develop policy or generate some kind of intervention to address these issues. This presentation is about the first element of that, learning about the burnout levels of our pharmacists. Our secondary aim was trying to figure out, are there any individual level factors associated with burnout? Anything we can measure. Now, I have to be honest about this. When I first learned about burnout, I had no experience in this area. I had to read the literature, just like many of you, whenever we get exposed to a new topic, we try to read the literature, try to understand the framework, and therefore try to develop an intervention. When I first learned about this, I was so focused on the individual level factor that it created this tunnel vision for me, that I started to ignore everything else beyond the individual. And this is going to have some significant impact on our results, and I'll talk more about that in a few minutes. So this took about a couple of years to get IRB approved because it was actually a prospective study. However, we had surveys. We surveyed our pharmacists who are academic detailers between April 2023 and May 2023, very short time frame, because we wanted to make sure we captured it at the same time period. And we sent a survey to all of our pharmacists who are acting as an academic detailer within the VA. Now, these pharmacists were those who had one documented encounter, so that way they were actually actively working as an academic detailer. And they had some element of their time dedicated to academic detailing. And I just want to thank Dana for helping us get that approved within the VA. This is a long-standing battle we've had for some time to assign time to the pharmacist to be able to do academic detailing within the VA. So at the time when this survey was sent out, we had approximately 123 academic detailers that were actively performing academic detailing. I imagine across the VA, this is sort of an impressive feat for at least program office. Now, we had a 41% response rate. Now, how many of you can tell me this is a good response rate? Okay. How many of you, when you get a survey sent to you, delete the email or not respond to the survey? I know Jason does. So this is pretty good, at least in my opinion. But it's not the entire representation of the academic detailers at VA. So take that with a caveat. All right. So what survey do we send them? Being the government, we don't try to use surveys that charge us money. There are surveys that do that. So we resorted to using surveys that were actually publicly available. And for those of you who are interested in doing a study on burnout at your own institution, feel free to reach out to me. I can give you the Oldenburg Burnout Survey. This is a validated burnout inventory that was designed for healthcare professionals. So if you're interested in administering this, let me know. I can get you in contact with the author, and I can also share you the survey. But there are two domains the survey focuses on: exhaustion and disengagement. Now, all of you have experienced some level of exhaustion and disengagement. And these are two domains that are quite important when it comes to burnout. Now, the affected elements of exhaustion include things like being affective, physical, cognitive exhaustion, and levels of engagement include things like depersonalization and being cynical. And I'm sure many of us have personal stories about these. We see these examples at work, at home, and in our professional lives. The other thing we added that was unique to this study was the single item measure of burnout. Now, for those of us that work at the VA, we send out an annual employee survey to all employees of the VA, whether you're a clinician or a staff member or some auxiliary personnel. We send an all employee survey nationally. We get a very high response rate. And on this survey, there's a single item, only one item about burnout. And it's this item right here. So we decided to include this in our survey when we sent it out to pharmacists who are academic detailers. Now, the survey is very simple. This one item is very simple. It's actually a validated item. It takes elements from the Mushlock burnout inventory emotional exhaustion scale. And it asks this one question: overall, based on your definition of burnout, how would you rate your level of burnout? And there are 5 choices. If you choose, I am definitely burning out, or the symptoms of burnout that I'm experiencing won't go away, or I feel completely burned out, that just tells me that you're burning out. It's a very simple item. If you answer any of these responses, you're burning out. Now, this is not very specific to what level of burnout you have. It just tells us, are you burning out, yes or no? All right. So for those of you that are not familiar with statistics, we did a linear regression model to kind of see what individual factors were associated with burnout. And then what we tried to do was try to figure out who had more than one symptom of burnout and what type of factors are associated with those burnout levels. So I won't get into detail about the demographics, but I want you to see the sort of variety of clinicians who are academic detailers respond to the survey. And when we look at the different domains of the Oldenburg burnout inventory, we see that approximately 86% of responders reported having moderate to high levels of burnout on this scale. It's a pretty significant amount. It's almost 9 out of 10 people who responded to the survey reported some level of burnout. And when we started looking at the individual factors, we found out that none of these individual factors are associated with burnout. Sex, age, the number of FTE dedicated to academic detailing, and whether or not you have to travel. None of these are associated with burnout. So it made us think about what are the potential reasons for this. And I've come to the conclusion that we've been looking at this from the wrong paradigm. It's not the individual level factors. We're all enthusiastic about our work, perhaps. We all are doing this, as Michael said, as a service to our community, which aligns with hopefully all of our values. So we have to think about maybe these are environmental factors, external factors are outside the individual level of control that could be leading to these burnout levels. So that's a train of thought that we're going to pursue in our future research. When it comes to the single item measure, whenever they respond to these responses, we can indicate they're burning out. But as you can see, this level of burnout is not captured very well with a single item measure. Compared to what I showed earlier about approximately 9 out of 10 responders had burnout, we don't see that level of burnout here. This raises some questions about the sensitivity of this scale and whether or not it's actually accurately capturing burnout levels in our academic detailers. So approximately 28% responded to the single items. Of all the responders on the single item measure, about 3 in 10 had some level of burnout. But no significant differences in terms of individual factors with this level either. So some points to take home from this. Academic detailers are experiencing burnout at the VA. And I'm sure academic detailers and all healthcare professionals are experiencing burnout in other scenarios and other domains. Now, this is one of the first, if not early, descriptive analysis of burnout among academic detailers at the VA. And what we're going to do with this data is repeat this survey every year for the next 5 years to see if the level of burnout has changed or the trajectory has increased. And even though we try to find individual level factors associated with burnout, and there are none that we could find in our sample, it raises the question of whether or not the paradigm that we were thinking of may be incorrect. Maybe it's not the individual level factors that are associated with burnout. It could be external factors, environmental, things beyond the control of the person that's actually responding to these surveys. And we're not clear how burnout among academic detailers affect retention. We hypothesize that it does, which raises the question of what other elements can be leading to retention issues. So our future studies will be doing surveys and interviews with academic detailers that left academic detailing or are thinking about leaving academic detailing and trying to figure out what type of things we can do as an organization to retain them as academic detailers. All right, some limitations. This is a cross-sectional design. As a result, we can't really determine causality here. We were unable to determine whether burnout was due to detailing or other factors, something to learn more about as we pursue this train of thought in the future. Now, even though we had a 41% response rate, still a small sample, about 40 to 50 academic detailers. We may want to think about expanding this sort of study design to include all academic detailers in the nation. And we use a different survey as opposed to the traditional Moschlock inventory, which is the most common validated burnout scale that's used in the United States and internationally. However, they usually charge for a license in order to use it. So we had to use alternatives. Some concluding statements. Burnout among clinical pharmacists who function as academic detailers is poorly understood. We realize this. Our initial hypothesis about individual level factors may not be correct. We need to think about the external environment. Now, our focus should be on understanding modifiable factors that healthcare systems can apply or implement in order to mitigate burnout among academic detailers and hopefully retain them in their profession. All right. And I believe we have this survey. So on a scale of 1 to 10, with 10 being the highest, how stressed do you feel in life right now?
Everywhere, or you can just shout it out if you're feeling wild.
This is nice. As a statistician, we like histograms that are normally distributed. But clearly there's a non-parametric distribution here. Almost bimodal. All right, thank you for your response. And I think, oops, we have one more. What's one thing that makes you feel better when you're overwhelmed? Chocolate, pets, family, food, reading academic detailing materials, right? Hiking, dogs, sleep, watching British baking shows, a smile. I think they have programming for that. Family time, ice cream for breakfast, prayer, hot bath, going for a walk.
All right. Well, we're going to wrap that part up. Thank you for that sassy 10 a.m. Response to all of this. And thank you, Mark.
All righty. Very excited to call up our next speaker, Dr. Sarah J. Popich, who is the National Clinical Program Manager with the U.S. Veterans Health Administration Pharmacy Benefits Management, AD Services. She is an absolute wealth of information, providing more than 13 years of experience in the field. We are so excited to have her. Without further ado, Dr. Popich, please take it away.
Thank you very much. So I'm going to now go in the unscientific direction of going with our gut versus what Mark just presented. So just so you know, we sent out a questionnaire to our detailers on the side or outside of what Mark was doing and said, we want to know about your experience, because we've been hearing from some of our program managers that their detailers were saying, I'm feeling really burned out. And we know that a lot of this had to do with what was going on with the pandemic. You're talking about people who like to socially interact with people. They want to go into the office. They want to talk to them. What was happening? You can do it on Zoom now. That's really exciting. I feel real connected when I get to talk to you on Zoom. Hello. I guess it's better than sending you a text message. But so we sent out this questionnaire at the same time. So we're going to talk a little bit about that and some of the techniques that we've put together to hopefully reduce burnout amongst our detailers. So I'm pretty excited about this. Like Mark, I have the same disclosures. He already went into it. I won't go into it again. All right. So I kind of want to start with a little history and highlight for some of you who have not heard about the VA academic detailing program that is a little bit different. Yes, our primary focus is getting our detailers out there, meeting with individuals, meeting their needs where they are out with those outreach visits. However, we also have a very multifaceted approach because we are an enclosed system. They have a lot of data at their fingertips. They've got a lot of things that they can do to help overcome some of the barriers we see. So I know that Mark said we had, 150 something detailers? Anyways, but that's not full-time equivalents. We have a lot of detailers who don't have a lot of time dedicated to detailing, right? So it equals about 74 full-time equivalents of what we have within the VA. And they work very hard to approach it, like I said, in a multifaceted way. We know for change to happen, especially in a large system that we've got going on, we have to have our leaderships involved. So they have to be able to interface with our leaders in an effective manner to make sure that our campaigns and our key messages promote that evidence-based care are lining up, right? So you can have that leadership support you. They also do a lot of things for campaign socialization. What do I mean by that? I'm talking about in-services, email blasts. Jason and his team make wonderful videos that they send out to clinicians to socialize the campaign. It's fabulous. Then they meet with the providers. And of course, when they're meeting with the stakeholders as well, they identify a lot of barriers. There's a lot of things that stop the knowledge from being translated into action, right? So they identify these barriers and they work on process improvement strategies so that it can be incorporated into the workflow. Once it's incorporated into the workflow, it's going to stay. And we have seen this with our naloxone campaign, right? We see it now where that trajectory, after they've been detailed and they've got those processes done, the numbers keep climbing and climbing and climbing for our at-risk veterans receiving naloxone. And of course, we also work on engaging our patients because we hear another barrier is, oh, that veteran's never going to want to come off that benzodiazepine or that opioid, or our veterans are never going to stop drinking or reduce the amount of alcohol they consume. So we've developed a lot of direct-to-consumer brochures that can be directly sent to the veterans so that maybe they come into the clinic and they have a conversation with the clinician. And one of our priority campaigns right now is alcohol use disorder. Of course, we don't have the study to prove it yet, but we've been hearing from the detailers that clinicians are saying, hey, those brochures are working. My veterans are coming in and asking me for help. They didn't realize that they were drinking way more than what they should be drinking. All right, so what do we do as our office? I have a whole table sitting over there. Raise your hands, office, folks. Yay, yay. We've got a whole large team that really helps us coordinate all these academic detailers nationwide. What do? Well, we try to standardize training. We use our ALOSA partners to help us with this, help us with the basic skills and the advanced skills training. We also host our trainings ourselves. Yes, thank you for all your hard work and helping us make detailers awesome. We develop educational materials. They help us design and make them beautiful. We love it. We are data rich, right? So we have a lot of audit and feedback tools. Those really help us identify those clinicians who may have the larger portion of patients that will benefit from the key message. It also allows the clinician to identify maybe at-risk veterans so that they can provide the service that's needed. Of course, the thing our detailers don't like is we've got a workforce or workload recording system that helps us identify who they've met with, how long they met with them, what the key messages were. But this is how we continue to evaluate the usefulness of our programs so that we can continue to fund our academic detailers nationwide, which is great. And of course, we have Mark, who helps put us together all these studies so that we can continue to publish and grow the literature around academic detailing. So as I said, we were hearing rumblings about how detailers were burning out. So we sent out a unofficial questionnaire, not a survey, it was a questionnaire about their experience. And we wanted to know what they liked about being a detailer and what they found very frustrating. So not too bad. They rated their overall experience as a detailer as about 3.8 out of 5 stars. Not too shabby, not too great. Things they loved. They loved improving care for our veterans, being able to see that aha moment as somebody implemented that key message that they had to help promote that guideline-directed care. They also loved feeling like they were a leader within their facility and the networking that they did, meeting with different types of backgrounds and clinicians throughout the whole entire facility. Unfortunately, 86% of the detailers, as you saw in that survey, reported feeling moderate to high levels of burnout. In our survey, it was a little bit lower. It was 65%. Could have been different detailers that answered, I'm not sure. But the things that they marked the highest that they felt like were contributing to their burnout and that they disliked most about their job is they felt like they were a burden to clinicians who were feeling burned out. Right? So you're going to hear burnout, 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 but they're having to meet with individuals who are feeling overwhelmed as it is. And they worry that, am I being a service or I'm just asking them to do one more thing and I'm contributing to that burnout. So that was the biggest thing that we saw there outside of, I don't like recording my visits. You require me to do too many visits. You don't give me priority panel providers. You do give me priority panel providers, the usual like dichotomy of I hate you, I love you situation that you get in every single survey. And you're like, I don't know what to do with that. I'm going to go with what I want to do. So there you go. I know best. That's what I always say. Okay. All right. So let's think about what we could do. So we took this information back as an office and we brainstormed together. And our primary focus was to say, what can we do as an office? It's all great to say, all right, what you need to do is make sure you get 7 to 8 hours of sleep. How many of you got 7 to 8 hours of sleep last night? Good job. I don't think I was quite there tonight. Tonight is my thing. Exercise. How many of you got your morning exercise this morning? Good job. Our numbers are going down. Oh, yes, I know. Somebody ran 7 miles this morning. Training for a half and then a full marathon. Congratulations. I love that. All right. How many of you practiced mindfulness last night and thought about the 3 positive things that helped you yesterday and got you through your day? All right. We got a few of you, right? So all those things that we can do internally to help us with burnout, but that's not, I mean, yeah, I can have yoga and meditation on our collaboration call and tell everybody to stand up and take a deep breath, but that's not going to really probably solve some of the issue. So we looked into the literature and things that kind of stood out to us of what we have control of, right, is continuing education. What can we provide to make them feel more confident when they go out and meet with clinicians? So that they don't feel like they're a burden. So they're doing that appropriate needs assessment. So they're meeting their needs. This goes into that professional development as well. What can we do to recognize them, recognize their accomplishments, and also develop them more professionally? We don't want to lose them to leadership positions, but we do, and that's okay as well. Also, increasing collaboration and mentorship were keys as well. And these are things that we could do in our office to help them. So that's what we did. We identified that potential opportunity to enhance training offerings and increase detailers' comfort with academic detailing. We went about it with a three-pronged approach. I'm going to spend the largest amount on our first prong you can see here, bringing back the Jedis. Thank you very much. So these are our joint education detailing instructors. We then worked on quality and clinical and quality process improvement training as well, because I pointed out that it's a multifaceted approach. And then communication with leadership, right? That was another topic that we needed to cover. So let's spend the most of I got the 5-minute mark. Let's spend the most time talking about the Jedi.
Sarah, we can cut into discussion a little. We have 25 minutes for discussion. So if you need 5 more, you're all good.
Yes, that's good because I can talk really fast. I don't think it means you're going to actually understand the words that are coming out of my mouth. All right. So the overarching goal of the Jedi, and yes, my boss, Melissa Christopher, loves Star Wars. So whenever we can do anything Star Wars-esque, we do. Right. But it's the overarching goal is to develop and enhance the multifaceted skills of our detailing community. We also wanted to build that sense of community as well. Well, we had a program back in 2018. We had a gap in which we didn't have a contract to help us with training. So we had to have a workforce to help us. Because back in those days, I think there was only 2 or 3 educational managers. Like we were pretty bare bones compared to this large group that we're getting now. And so we needed help. Woo, woo. Watch out. I'm going to be breaking water bottles here, sticking out there with my hand movements over here. So anyways, 2018, we had this workforce, but really we only used them to help us with our trainings. So they helped facilitate those lovely practice sessions that everybody loves, right? The real play, role play, academic detailing sessions. So they helped us facilitate those small groups. And they gave a few presentations. Well, we surveyed them and said, hey, we're thinking about bringing back the Jedis. What did you love? What did you hate about it? They said they absolutely loved all of it, but they wanted more. They wanted us to give them more opportunity to educate, to lead. So we are relaunching right now. We've actually done this for the last year. I'm really excited about it. And we had several goals. 1, we want to take this elite workforce and increase their knowledge and skills. We also need to increase our capacity to train detailers because unfortunately, it looks like we may be going into another gap because that's how the VA works. We wanted to increase especially that sense of community, that peer mentorship and communication and networking and the sharing of best practices. And of course, we want to engage and retain our top detailers. Those individuals who've been doing it a long time, who are rocking it, who continually show change, we want to keep them engaged and we want to keep them involved. So we actually have a Jedi in the room. Cassidy, would you like to wave your hand so everybody can see? Yes, yes, there is one of our Jedi detailers, right? So we had quite a few applications. We accepted 10 new Jedi detailers. We based the selection on multiple things: years of service, outreach, how many trainings they had attended, other skills that they brought to the forefront, right? So we wanted to make sure we got the cream of the crop. We also had 4 individuals who were still working as academic detailers. All that were still academic detailers chose to become Master Jedi, right? These Master Jedi help us in the coaching and training of our new Jedi detailers, right? So it's not just me saying, well, yeah, this is what you do, right? We have people out there, boots on the ground, meeting with 300 individuals in a quarter and talking about academic detailing, right? These are the individuals that are helping coach the other individuals. We requested a 2-year commitment. I think what is scary is I don't know what we're going to do when we open up the new application for next year because nobody wants to leave. Even when they take new positions, they're like, well, I still detail a little bit. Can I still be a Jedi? Right? So we're like, okay, this is going to be, we're going to have some serious discussions on how to do this. And you can see our detailers listed there. So what have we done this last year? Well, we have a council meeting. Thank you, Michael, for telling me I couldn't just call it a meeting. It's Jedi, so it needs to be a Jedi council meeting. All right, good. We're doing good. We then signed them up for the accelerated LEAP program. I'm going to talk about that in a minute. It's that process improvement, quality improvement. They were the ones that did that. We got really blessed. We had the funding to do an in-person upskilling conference that happened in March of 2023. We had one of the master motivational interviewing trainers for the VA come in and assist us. We also had this excellent individual who really worked on small group and large group facilitation as well, and helped upskill all of us in our capability to facilitate meetings. Because we know sometimes when we're running a meeting, we have strong personalities, and it's nice to be able to handle those. And we have made a little notebook thing now where it's how to deal with, when you're doing your small practice session, the crier, the person who's nervous, right? So we have all this put together to assist them. So we had some facilitation training as well. We also have Teams channels separated out for all the different academic detailing topics that are going on in the VA. We weren't getting a lot of traction. So the Jedi agreed, you know what? We think this is a great way to communicate and collaborate and share. So they are constantly on there for campaigns. Hypertension. Hey, how'd you upskill on this? How did you approach this topic on this? So they're sharing all this in the Teams meeting so that somebody doesn't have to go, oh gosh, I thought I saw an email a long time ago. I'm searching for it. Can't find it. Probably deleted it. Versus just going to that Teams channel going, oh, I'm detailing on heart failure. I want to see what people are doing, and helping not recreate the wheel as you encounter all these barriers, or sharing best practices or resources that you utilize to upskill, or discussing the newest evidence that just came out. They've also helped us with facilitating national trainings. Since they started, they have been involved in all of our contractor-led trainings. So they have helped us with presenting to leadership boot camp. In addition to that, they have joined all of the ALOSA-led basic skills and advanced skills to provide that VA perspective. Because that's one thing we always get in the VA is they don't know where we're coming from. We're a little bit different. So they provide that VA perspective. And it also gives them the opportunity to meet new detailers in the basic skills training, right? And form that mentorship relationship. And we don't have to make it a formalized process. And I'm going to talk about that next on the mentorship. I skipped that, but the academic detailing chit chat calls as well, right? So let's go into what this chit chat call is. And this was created by the Jedi because we talked about one of the key formats we wanted to do is have mentorship. And they said, well, you know, the formalized mentorship feels like a burden. It feels like burnout, feels like too much work. You have to meet with the person so many times and talk about all these topics, and it's just too formalized. We want to do something a little more informal and see how it works. So they came up with the academic detailing chit chat call. And it really is an open forum designed for collaboration, sharing of successful strategies, and enrichment of our academic detailing community. They were hoping that it would be an efficient way for that peer-to-peer mentorship. And I've heard from a lot of the Jedis outside of this call, like people feel more comfortable than reaching out to one of their academic detailing colleagues and say, hey, I've got a question for you. Can you help me with this? Right? They feel more connected with it. And really the hope is that it's a safe place for detailers to ask questions and seek guidance. One of the things they asked is that national office doesn't join. We said, that's too bad. I'm still going to lurk because I need to know what's going on with everybody out in the field, because we make them feel a little nervous. I hope not. That's not the goal. Our goal is to support and build them up. But we have several topics: facility buy-in and integration, right? So this is a 10-minute topic done by the Jedi on strategies they've utilized for these several topics here. Our newest one that's going to be coming up that I'm really excited about is being a service, not a burden, to go with that, right? And they're going to do a 10-minute didactic presentation. And then we open it up for questions from the field or sharing of things that they have done. So really trying to build that up. We do sometimes have people strategically placed so that they can go through that and build that conversation, but that is one of the main aspects there. So our Jedi experience. Basically, they love it. They would all recommend it. They feel like it has made them better at their jobs. They've grown their community, and they don't want to give it up. As I said, you can see some of these quotes we have here. literally saved me in this job. To me, that says, hey, we helped with burnout right there. Made them so much more excited for academic detailing, gave me a different perspective because of other people's different practices. It's been extremely beneficial for me, reinvigorated and excited about detailing again, instrumental to my development as a detailer. Loving being able to disseminate the solutions to other detailers across the nation. So we at least know that it's helping our Jedis. Now, we may have to questionnaire again to see if it's helping the other detailers. All right, so I've got one more minute. I will go through these last two strategies fairly rapidly. But like I said, we wanted to increase competence on process/quality improvement strategies. We worked with our partners who had a 6-month longitudinal program that trained clinicians on this. We condensed it to 3 2-hour boot camps with homework in between. We did the Jedi so we could get good feedback. What did we find out from that? Well, they liked the training. The training was well run. They learned about new tools that they could use, like the affinity diagram for brainstorming and prioritization. Like they liked some of the tools that they learned, but they felt like it was too shortened, too disjointed. They didn't know when to apply it. So we're taking it back. Our partners in LEAP are going to go out and they're going to interview detailers and find out what they would really need for this type of training and what depth and breadth do we need to make it better for the detailers. Once again, we worked with our partners because we had heard from our VISN program leads that an area that their detailers need to be stronger in is communication with leadership. They needed to be able to provide the succinct presentations and work with stakeholders. Our first training didn't go so well. A lot of factors going into that, but the trainings after that, they loved it, right? So they all agreed and strongly agreed that it was a practical value for them, learning these communication skills. And it really had a succinct structure that they could go through to make great presentations. And they enjoyed, of course, that collaboration, the group talking as well. And 96% were likely or very likely to recommend this course and use the skills and knowledge gained in the course. So with that, our training innovations have been well received. We're going to continue to explore additional ways to incorporate the process improvement strategies into our detailers' practice. And I think the Jedis are here to stay. We are thankful for them and the value that they provide to our community. All right, with that, we're ready.
All right, so what we're going to do is give Mark and Sarah some mics. I'm going to swap spots with you. So if you don't mind taking this back.
And let's make sure Mark has a mic. All right. Thank you guys so much. Come on up. And we can get the camera on these lovely folks versus me. That would be wonderful, Kens. Thank you. All right, so we are going to ask these lovely folks some questions. Before we do that, I want to always address the elephant in the room, which is FOMO, jealousy, about how the VA does have a lot of resources that many folks out here who are lone rangers, lone Jedi, would love to have. And so as a quick transition point and translation point and shameless self-promotion, we do have quite a few programs. If any of you don't have that kind of community yet within your own team, or maybe you're just riding solo, so do talk with our home team. We have regular check-in points to build the kind of phenomenal community that Sarah was talking about, so that you all can feel connected and have some resources from us. But without further ado, I just want to ask the folks who are live streaming to start populating the chat box with questions, which it looks like are blowing up. So without further ado, please raise your hand if you have questions for Mark. All right, I see one right up front from Jerry. So if we can get him the mic, Vishal, that would be lovely. Oh, you have a mic. Amazing. Look at all that. Jerry, over to you.
I have two mics, this one and that one. First, I want to thank Sarah and Mark for both their presentations and also and Melissa in the ether for creating and running a program that is just a kind of national and international beacon for anyone in academic detailing. It's always great to hear from you guys. I got a specific question for Mark, which is, how do you think the level of burnout in pharmacists who are academic detailers in the VA would compare to the level of burnout among pharmacists in the VA in general, and then even larger healthcare professionals? Because we all know that all of us healthcare professionals are burned out. And I'm wondering about whether I can imagine that academic detailers would be less burned out, maybe because they get to talk to other humans and be a source of information, or more burned out because they got to knock on doors and people don't always want to talk to them. So have you thought about extending that to other VA pharmacists for a comparison?
And we did have a similar question in the chat. Did you think about maybe doing a control with a group of non-detailer pharmacists? So lovely synergy there.
I think that's a great question. Just to reiterate, Jerry was asking whether or not I could compare the academic detailing pharmacists to other pharmacists within VA, whether or not we would get comparable results. This is something that we've been thinking of doing. The IRB we submitted didn't include non-academic detailing pharmacist control, but we would like to do so. This is the reason why I added that one single item measurement of burnout that the VA sends out to all employees. We could use that in order to measure the level of academic detailing among pharmacists who are academic detailers versus pharmacists who are not. We do have specific codes for our employees. We can categorize them as such. However, based on what I just showed you earlier today, there seems to be some sensitivity issue with the single item measurement of burnout that captures burnout the way the Oldenburg burnout inventory does. So I'm not quite sure how specific it would be for the non-pharmacist academic detailers, but it's a very good suggestion. It's something that we're planning to do. But just to add one more thing, Jerry, I do think I hypothesize that the academic detailing pharmacists likely have lower burnout compared to the non-academic detailing pharmacists, primarily because the selection bias of getting an academic detailing pharmacist, there's a lot that goes into that. And part of it is the alignment of what they're doing with their own values. So I do think there is some kind of satisfaction there that would mean that the academic detailing pharmacist is quite happier than, say, a conventional pharmacist operating like in the lines, filling prescriptions.
Thank you, Mark, and thanks, Jerry. We have a great question from Anishka Walker online for Sarah. Anishka says, as a program manager since the reinitiation of the JEDIs, what benefits have you seen from a national program standpoint outside of what was shared in the presentation? So sort of the larger benefits.
Well, we haven't sent out a survey yet. I have been hearing less grumbling from the program managers saying my detailers are burned out. I see more interaction. I see a lot of things going on. And personally, even within our own office, I think we were all struggling with burnout. I was. And this reinvigoration and restarting of this JEDI program has given even myself new life to this position because I feel value in watching others grow. And I think especially during the pandemic, I couldn't see anybody grow. And so being able to pull all this together has really helped. Now, in the future, would we like to send out another questionnaire and see, can we compare? Yes, but my gut says by the interactions I'm seeing with individuals that yes, we are making a difference. And of course, I'm a very positive person. I wouldn't say, nah, it's not working. Let's stop.
Wonderful. Other questions from the audience? Throw your hands up. We've got quite a few down here at these front tables. Thank you, Vishal. All right.
Just a follow-up question just about the VA. So as a Canadian detailing service, just to learn a little bit more about how many pharmacists the VA employs and how many of them do detailing, just to get a little bit more perspective on that, roughly.
I have no clue how many we employ. A lot. A ton.
I think Jason has the answer to this one.
There are 10,000 pharmacists.
10,000.
10,000 pharmacists, 4,000 clinical pharmacists, and you said the number of detailers.
About 123 at the time of the survey.
So it's a highly selective group. These are coveted jobs, I will say. The number of applicants per position are usually pretty high.
All right. We had a few more questions up front here. Thank you, Vishal.
Hi, thanks for a great presentation. I just had a question about recognizing achievement and that being such an important part of retention. What have you found to be the most effective ways to do that?
So we have been making sure that we highlight our individuals who are achieving program success and recognizing them on national calls. Not just recognizing them, but having them actually present what they have done on national calls so they feel that recognition. I know Cassidy has done several presentations for us, even doing things as simple as, this is how I get appointments. And this then recognizes that individual as a leader that others should reach out to and get advice from, especially those boots on the ground advice. They could reach out to me and I could say, yeah, back in my day, oh man, 12, 13, too many years ago to count. I did it different. I couldn't just instant message somebody. I had to either cold call them on the phone, or send an email that they never read. Right. So things have changed, and recognizing them is really putting them on national platforms. We have them come to our operations board meetings where they get to fly in and present in front of our national leaders and talk about how the Jedi experience has influenced them. So we try to recognize them that way. We're also going to be recognizing the Jedis with something. We're determining exactly, but it'll be some fancy certificate because we work for the VA and that's about all I can do.
Fancy certificates, people. This is the answer you came here for.
Just make a fancy certificate. You can't even put it in a frame in the VA. That costs too much money and I'm not allowed to get that kind of gift. Maybe I can send it to you via.
Well, I have a follow-up question about this. For those of you who can't get, or don't have the kind of resources for, or even the staff and, people around to get that kind of reflection, which sounds so important and increases morale. And as you said, shines a light on people as leaders. How would you recommend translating that to smaller teams in ways that are fairly cost-effective or free?
I think the first thing you need to do is identify individuals who are maybe tackling the same topic that you are tackling, right? Using NaRCAD as a resource so that you can connect with those individuals. And many of you have some form of virtual communication. We do a lot of communication on Zoom, even just having a quarterly meeting, a monthly meeting, with a set agenda so people don't feel like you're wasting time, but ways to share those best practices and communicate and collaborate really helps the individual who is often the lone ranger, right? Many detailers, I think the problem is you don't have a whole group or cadre of individuals that you're working with. You're often by yourself in this territory. And the other person is maybe 3 hours away from you. So you're not going to be hanging out with them. So you got to figure out a way to build that community. And it can be as simple as, getting together, doing icebreakers. Sounds silly, but a weekly icebreaker really makes a big difference. And sharing those best practices amongst your community with the resources that you have.
Thank you, Sarah. And can't say enough from, a national, and I guess we can say global because we have someone from Australia. Thank you, Deborah. And also Canada, that when we are running our community calls, we do see that folks just need to be seen. And that is something you can do for free by reflecting. I see how hard you're working. I really loved what you said about X. And again, just encouraging that as a culture within and across our academic detailing community is really important. So thank you for that. We have one more question. Adrian?
Great. This question is for Sarah. I don't know if it's more so of a question or statement or however you want to go about it. But
Do you mind speaking just a tiny bit louder?
okay.
Thank you.
My question is, as a project manager for academic detailing in Maryland, we engage, I guess, in something similar fashion to your chit chat meetings or monthly TA calls. What exactly do you do to get engagement from your detailers as far as being able to speak up more freely and, kind of really speak their minds and give their experiences without trying to, I guess, say, pull teeth or try to force information out? What techniques do you provide or offer to help detailers to speak their mind and really say what's really going on with them?
So I always have my other Jedis planted in the audience and prepared to bring up a topic so that once somebody else speaks up, people feel more free to speak up. I also believe in the power of silence. It is okay to be silent until somebody gets uncomfortable enough that they speak up. Sometimes just chatting in the audience. I also think it's okay if you know of a best practice that's been going on to say, I remember you mentioning something so-and-so. Do you mind explaining this to the group? Because you're more the expert than I am. So really, if you know things, it's that background work that you have to do, especially in a virtual environment. It is hard to get people to speak up. We struggle with it, especially on our other national call. It's so big that people don't want to speak up. We've changed our topics. And in changing our topics, they feel like they're more experts. And people are speaking up more on the chat now as well. But don't be afraid to have those plans, I think. That person in the audience that is either going to ask the question or going to share information to start that conversation.
Wonderful. And we have 1 minute left. Thank you, Adrian. I know it is hard to get detailers on your team. I've seen your program over time to tell you what's not working. So again, encouraging that, because that's the way that you get the support that you need. Easier said than done, but building that culture sounds so important. We're going to wrap up. I have one quick question for Mark. Mark, if you had nothing in your way and you could figure out or access a bit of data around burnout in general for all the detailers at the VA, what would it be?
I wanted to know more about their environment that they're in, what kind of support network they have, because I feel like the individual level factors based on our study doesn't seem to be associated with burnout. So it could be something external, systemic, that we need to understand more and figure out if we can actually modify those factors in order to improve burnout levels in our pharmacists.
So getting down to the root issues versus a Band-Aid solution, it sounds a bit like.
In a way, but also to generate new hypotheses to test, because we're not quite sure if these environmental factors have any impact.
One more for Sarah. What would you want to know if you could just kind of Google, why are they burnt out, or Google something that you were dying to know?
Well, I would really like to know, is the Jedi program helping the detailers in the field? That's what I'd like to know.
Yes. Are we having
my magic thing?
Are we having an impact? And that's something we're going to explore over the next couple of days. Thank you guys both so much. All right, we have a 15-minute break. I know we stole 2 minutes from you. If you can come back at 11:02, we would greatly appreciate it. And live streamers, go ahead and stretch. Thanks, guys. is 11:02. So as promised, we are going to get going so we can stay on time. Everyone from the Tasty Snack and Coffee Zone, please come back. We miss you. Okay, but not. Okay. You don't need that. Okay.
All right, welcome back, everybody. Hopefully, while the coffee was brewing, we're brewing some excitement for some morning detailing learning. They say the conference may have had registration, but the dad jokes are free. You're welcome. All righty. As we settle back in, let's get excited for our morning of field presentations. Our topic today is going to be leading the conversation, detailing on some highly stigmatized topics. So while this may be topics that are challenges for us in the world of detailing, the way we approach them has some really, really novel approaches. And we're going to learn from some great experts in the field on how they do it and how we can use this into our own practice. I'd like to go ahead and get started with Dr. Trish Runn, who is the Clinical Service Director for the Center for Effective Practice, who's been detailing in academics for a while, is also practicing at Mount Sinai Hospital in Toronto, and is, again, just a wealth of knowledge and has so much great experience to share. So without further ado, I would like to call up Dr. Trish Runn for her presentation. Let's hear it.
Thanks very much. Quite honored to be here to discuss with you our mental health detailing and how it's helping to lead some really great conversations. First off, my disclosures. So I'm an employee of the Center for Effective Practice. I'm also a part-time hospital pharmacist at Mount Sinai in Toronto, and I have no other relevant disclosures. So today we're going to get into a bit around what we've been doing in the field, but also try to put it into the larger context of the importance of having these open mental health conversations. And after that, we'll be happy to take some questions about both the barriers and the enablers that we've encountered in our detailing on this topic. So just to open this up a little bit to the audience. And please feel free to share only if you're comfortable, both here and online. But we want you to just share with us in what ways you've seen patients or loved ones experience stigma related to their anxiety or depression. So please feel free to pop up your hand, to type something into the chat. And while you're doing that, I just wanted to share what we encountered in the field as well, which is that when we approached physicians and nurse practitioners about this topic, the first thing they said to us is, thank you for doing this. And this is all our patients. This is everybody that we talk to. So whether you are diagnosed with anxiety or depression, or whether it's a loved one, a patient, a friend, these are touching everybody. And so it's likely that we all have someone that we're thinking of or an experience that comes to mind for the importance of this topic. So yes, I'm seeing some answers in the chat. So dismissiveness, it's all in your head. Statements about appearing weak. So we can see there's a lot of stigma around weakness, around imagining everything that's going on, being lazy. Telling people it's as simple as just doing yoga. Yoga is great, but again, this is a big problem to solve. Just get some exercise, people seeming to know your situation and what's going to help you. And so you can see there's a lot, we're up against a lot of ideas here that may be making it very difficult to start this conversation. People are hiding it. They feel shame from both themselves and their other people in their life. Suck it up. Can't you just get control of this? So there's definitely a perception here that this is all in your mind, and that by simply changing your attitude, maybe taking a walk, doing some yoga, you're going to be able to get over this yourself, and you really shouldn't be bothering other people with it. Feeling separated, feeling isolated from others, something we've all experienced just as a function of being part of this global pandemic, and something that we talked about with respect to burnout. We're all feeling a little isolated. So on both sides of this conversation, we're having the issue of just not quite connecting. Why are you overreacting? You just need some sleep, So people want to help. And these responses, although they feel a bit dismissive, are coming from a good place. People do want to help, but there is this disconnect about how exactly to have the conversation. So thank you, online folks, for your responses. Anyone here in the audience feel comfortable sharing anything about what they've observed regarding the stigma? Okay. Thanks, everybody. Oh,
Sure.
I think sometimes when you have or you're working with providers who are a little bit more old school and they can't see it under a microscope or be able to diagnose it through blood work or whatever, it's really hard for them to make that connection that it might be something more than just running labs and doing all the usual things. It might actually take some more conversation, and whether they're through no fault of their own, whether they're strapped for time, they have too many patients, they just aren't able to properly help.
thank you. And that really highlights a lot of what we found when we started looking into this topic as well, is that you can't see this, you can't test it on a lab, and providers are busy. There's all kinds of things already in their face that they've got to deal with. They've got 10 minutes. This is not going to fall to the front of their to-do list. So thanks everyone for sharing. I just wanted to share a couple of statistics. I'm not sure why, but this one slide is not really popping up here. It's the one about 16 years to seek help. I seem to be...
I think the slide deck is depressed and anxious. All right.
Feeling a little shy. And if it won't go, that's okay too. I can just...
Yeah. I don't know the key messages. Is that what you're looking for?
No, it's the 16 years to seek help.
Well, if you can share it.
I will share it. So I had a great slide about just two opposing statistics that I found really interesting that I think very well illustrate the importance of the topic of mental health conversations. On the one hand, there was a big circle with the number 16 in it, and it said people with anxiety disorders take a median of 16 years to seek help. And then on the other side, we had the statistic that about 50% of people who die by suicide see their primary care provider in the 1 month before their death. So you have 16 years, 1 month. People need help, and they are seeing their primary care providers who are in a position to provide it. But for some reason, that conversation is not happening. And we tried to understand why. And thank you, everyone, for sharing what you did, because I think that highlights the reason why these conversations are not happening.
Sorry, real quick, we're going to put that slide up on Twitter right now. If you guys want to look at those statistics, it's very impactful to see visually.
Thank you so much. So in an effort to address this, we developed an academic detailing intervention that had two key components. The first was one-on-one academic detailing visits, both in person and virtually, with family physicians as well as nurse practitioners. And what we were trying to do there was to understand their needs, understand the barriers and stigma they were encountering, and to help connect them with therapeutic information, but also local resources. And then the second component of our intervention was a website and EMR tools. The EMR tools were developed in partnership with the eHealth Center for Excellence as part of an initiative called Evidence to Practice, where we brought Ontario quality standards together into the EMR for practitioners at the point of care so they can provide the best care. And then we also have a website, cep.health, where we have a number of practice tools, both on anxiety and depression, as well as many other clinical topics. And they include things like drug charts, algorithms, as well as a special feature called talking tips, which is relevant to what we're discussing today, because it's just quick little scripts that providers can use to start a difficult conversation, to respond to objections, to help navigate those tricky waters of a conversation. And this topic is not our first foray into difficult conversations. Our very first academic detailing topics were actually opioid prescribing, chronic pain, and opioid use disorder. And so we recognize the need for such tools when we first started doing these topics. So our team researched the literature and identified relevant guidelines, resources, and practice gaps. And as a result of that research, we developed 4 key messages. The first relates to screening tools. And so what we wanted to do was to identify validated screening tools that would screen patients at risk for anxiety and depression in a culturally sensitive, LGBTQ plus friendly and trauma-informed manner. And the reason that that's important for conversations is that when you look back to those statistics of 16 years, 1 month, some of the reasons these conversations aren't happening is because there are so many barriers in the way. The providers who may not know the person is at risk, the patients who may not feel safe to share their concerns and who may feel that they might be dismissed. So trying to understand the best way to bring these things up during the screening process. The second key message related to shared decision-making in individualizing therapy for depression. And here again is where the conversation is continued. It starts with screening, and then it continues through the therapeutic discussion where the provider and the patient share information, and the patient shares their values, their preferences to help shape the therapy that they're likely to adhere to and find effective. Next, we had a similar key message for anxiety, talking about step care and shared decision-making there. And finally, we recognize that that is just the beginning of the conversation that needs to happen, that a patient and their provider are going to start this dialogue, but that the dialogue continues when the patient leaves the office. So they need a supportive context to be able to heal from anxiety and depression. And to this end, our 4th key message was to help patients and their caregivers find accessible, affordable local resources and supports so that conversation can continue. So here's what we found in our visits. We conducted 157 visits. 33 of them were with nurse practitioners and the remainder with family doctors since the topic launched in April of this year. About 60% were virtual. Prior to COVID, we were 100% in person. During COVID, we were 100% virtual, and we're very happy to see that the in-person component of our visits is bouncing back. So that's happening. And the most interesting statistic here is the 44-minute average visit duration. And what's interesting about this is that our average for other topics is around half an hour. But for this topic, we were having longer, richer, more nuanced conversations. And as a result of that, that's where we were starting to get people into a safe space where they could share their own professional burnout, their own concerns with how they were going to help these patients, plus over 1,800 tool downloads. What were people asking? Well, there were the usual technical questions around the drugs, but there was an added dimension here around having access to free counseling. And just as a context, in the Canadian healthcare system, we're very fortunate to have hospital visits, doctor's visits covered by our funding, but counseling is not. And so you're running anywhere from $150 to $200 an hour. We find that that's not necessarily accessible. And so those conversations are not happening. As part of our detailing, our local detailers get to know their regional resources very well and understand where the loopholes are in finding free or sliding scale counseling. So that was a huge part of this. Barriers we encountered are similar to what you identified. So the shame, the cultural stigma, and the long wait times and lack of access of someone to talk to. There's another important barrier here, and it didn't make it necessarily into statistics because it wasn't something we tracked, but many of our detailers can attest to the fact that when we went into these conversations, it wasn't just about the therapeutics or helping patients, it was also about the provider's level of stress and burnout. And many of them confided to us that they found this a safe space to ask questions, to talk about the frustration they were experiencing with somebody who was supportive. Tools we developed were to identify free counseling resources, and particularly for specific populations who may encounter very specific barriers that are different, such as Indigenous patients and newcomers to Canada. We identified some medical consult services where a family doctor or nurse practitioner could speak with a specialist within usually same day and certainly within a week. And then there were the resources, including our practice tools that offered those talking tips we mentioned earlier. So just a few concluding remarks. This was a huge area of interest amongst providers. And given everything that folks have been saying all morning about burnout, I think it's probably no surprise, both amongst providers and the patients they care for. We did identify significant levels of burnout and the need for accessible, culturally sensitive resources to help people have those conversations around mental health. Fortunately, in the pre-visit training, we did identify several of these barriers. And so we were able to offer things like our talking tips in our tools, longer visits, and the skill of our amazing detailing team in identifying those resources that were even hyper-local. So what's around the street from your office? What's in your community? Where can people go for help to respond to these challenges? And we also identified another really important theme here, which is a part of a journey we've been on for the last year or so towards diversity, accessibility, inclusion, and respect in everything that we do as an organization and also everything we do as detailers. So trying to give more than lip service to this and actually make foundational changes in how we do things, both in recruiting, in how we approach providers and how we do our training as detailers, and finally in the information and resources that we're able to offer. To this end, we're engaging at a deeper level with our communities and with people with lived experience and bringing them into our process of developing our training. So with that, I wanted to thank you for the chance to speak to you today and share our mental health intervention, and just invite any questions that you may have. Raise up your hands or in the chat. Thank you.
Trish, I actually have a question here from Elizabeth Fowley-Mock, who is live streaming in from Maine. She wants to know, how did you get access to providers? And, says that, of course, it's possible that the Canadian structure is different than getting in to see American PCPs. So any thoughts on that?
Fantastic question. And I have to say that that's probably a struggle we can all identify with. This was a pretty hard one. As our 10th topic, we had several existing relationships with providers who said, what have you got next? Oh, yes, sign me up for that. So those were the easy ones, our existing folks. To the end of identifying other providers, I think we have the same struggles that you have in the United States. We basically pound the pavements, we send out flyers, we call, we fax, we go to conferences, we try to network with people that we already know to spread the word. We try to build ourselves into a service that provides valued information and communicates on a regular basis so that we encourage people to share and just slowly but surely build it up. We've also been very lucky in the last couple of years that we've received funding to speak with nurse practitioners. And we've found that nurse practitioners are pretty enthusiastic uptake of the service. They are eager for the information and happy to have those longer discussions. So we've been lucky there as well.
All right. Who else has questions for Trish? This is such a rich presentation, and especially talking about the stigma around mental health. Any other questions, reflections? We also will have the opportunity to have a larger all group discussion at the end of these field presentations. We have room for Jackie Travers here from Oklahoma to give one more question before we transition. Jackie?
Right. Yeah. I was just wondering if you saw a difference in the way providers embraced or approached some of your LGBTQIA, trauma-informed care. How did that kind of shake out?
Thank you so much for that question, and extremely well to our discussion. So I can only speak anecdotally at this point. I will say that as a service, we aim to be data-based and to gather information in Salesforce with our post-visit surveys on, are you feeling more confident in translating the evidence to practice? Was this valuable to you? Were there any specific points that you really found hit home? We haven't concluded the topic yet and have a lot more visits. So we don't unfortunately have that data, but I can say anecdotally, I have seen a difference as a detailer. The conversation, we're reaching more people, and we're certainly getting the discussion going around what does it mean to have cultural sensitivity? What does it mean to have trauma-informed care? What does it mean to make your office a little bit more LGBTQ plus friendly? You know, putting up posters, having, you know, asking people's pronouns, sharing your own pronouns. There's lots of things we were able to share that I think maybe did make an impact. Some simple, straightforward things, but we'll look forward to sharing data when we have it.
Thank you so much, Trish. That was lovely. I do believe we have time for perhaps one more question. Yes, over yonder. Thank you. It's Tony from Alosa. Thanks, Tony.
Great. I had a question. Do you have follow-up visits as part of your detailing efforts, or is it like you have a one visit for 44 minutes and that's it? Or do you have recurring follow-ups with the same pattern?
So we try to foster an ongoing relationship with the providers. And what that looks like, generally speaking, is we offer a follow-up if they're interested, but we don't enforce it. We don't require it. But what we do is we have a follow-up email where we say, here's a summary of what we discussed. Here are the resources. Please reach out to me if you have any questions. And our next topic will be X. And so some people are very, very enthusiastic about the follow-up and do take us up on that. I think it varies by region as well, but there's definitely an open invitation for a follow-up. And then what we also try to do is if they don't sign up for a follow-up, we go to our next topic and we inquire about the previous topics. So if we come to them on COPD, then we say, oh, by the way, how did it go with that tool? I remember you said you were going to do this. So also we try for continuity through tracking our visit information in Salesforce. And there's a field we have that says practice changing information provided. And in that one, we say, we encourage them to use this screening tool, or they said they were going to put some posters up in their office, or they said that they were going to try this. And so when we see them again, we say, oh, how'd it go with X, Y, or Z? And then that just makes it a little easier. Thanks for your question.
Okay, I lied. We have time for even one more because you're so succinct, Trish. Thank you. We have a question here from Amy McSweeney on live stream. Just a broader question about CEP before we transition. How do you all come up with detailing topics like this? How do you know what direction to go in and what topics to select?
Okay, yeah, fantastic question. So I want to preface it by saying that CEP is a not-for-profit organization, and we receive funding from the government at an arm's length through our Ministry of Health to tackle topics of high need and areas of practice gaps. And so together with our advisors, who include people with professional experience, lived experience, caregiver experience, as well as the folks at government, we try to come up with a list of topics that either have new guidelines or information, have practice gaps, or areas where they really haven't been addressed with other continuing education. And then we also ask our providers too, what do you want to see next? So it's kind of a bit of all those things put together.
Awesome. Thank you so much, Trish. And thank you everyone for your questions. Round of applause.
Thank you.
All right. Well, we're really excited about
that was seamless. Being able to have conversations about stigma more and more, right? It's a topic that's important. It's not going away, unfortunately, but I think our community, you know, you all and everyone on live stream and those who aren't with us have been really starting to get hungrier and more expressive about how do I have these difficult conversations? And so whether it be about depression or whether it be about opioid safety or everything in between, there are so many topics that come with this stigmatized context, and trying to flip that and think, how do we approach things with more inclusivity, and then also not shy away from saying, hey, we need to talk about these things, and we need to talk about how we talk about these things. And so it's my absolute pleasure to invite NaRCA Cabayas up to talk from UIC a bit about their extremely tenacious campaign to detail across the entire country on opioid safety. NaRCA is just sort of a queen who wears so many different hats. And, you know, I was thinking about saying, wow, she does social media. And then she also organizes, you know, communication among the team, and she details and all of these different things. But I also want to think about the burnout context, right? There's so many ways in which we pat ourselves on the back for doing a lot. And saying, oh, wow, that person's tireless or works 80 hours a week. So I want to go back for just a quick second to the poll results for Mark's presentation around chilling with your dogs, taking a break, taking a nap, and say, NaRCA, you're awesome. And also take good care of yourself. But first, come present and make us smarter. Thank you, guys. Please help me in welcoming NaRCA.
Thank you, Bevan, for that introduction. I will say lobster rolls, every time I come to Boston, is an immediate thing, definitely something that I do to take care of myself. So I'm going to jump right into this, apparently, with a poll question here of how many different types of providers or clinicians are you detailing? And so examples of provider types could be physicians, nurse practitioners, pharmacists, nurses, etc. Just to kind of get a sense of where everybody is at, or perhaps you have not detailed yet and are still developing your audience. Okay. Okay, great. So a lot of us are detailing a lot of different types of providers. So that's great to hear. I'm not very tech savvy, so I apologize if there's any issues with some of this. I want to start with a brief history of our academic detailing program, Illinois Advance at the University of Illinois, Chicago. Essentially, there's three primary phases over the last 6 years leading us to where we are today. We started out as a small group working in Chicago with one local health system. Then we expanded throughout the entire state with a significantly larger group of 30 plus pharmacists and detailers and more established organization collaborations. Then more recently, we skyrocketed to provide academic detailing services nationwide and across multiple healthcare disciplines through an FDA REMS grant. So today's presentation will focus primarily on this REMS program to advance opioid safety beyond Illinois state lines. One of the common challenges that many of us encounter, no matter the size of our team, is when we explain AD to clinicians and providers, they say it sounds invaluable. It's a novel service. They're very excited to share our resource with their team and their leadership, but then they smile and walk away. So how do we ignite the flame so that they can leap forward and actually engage in our academic detailing program? With Illinois Advance, we've had some limited success with the traditional outreach and social media efforts, cold calls, pounding the pavement, et cetera. So I wanted to take this opportunity to share some of the innovative approaches that our team has implemented in the past year in conjunction with this REMS program. So in terms of outreach, we invested a little bit and got a program called Constant Contact. It allows us to do email blasts and allows for smoother mass emailing. We can do analytics, address any spam or junk issues. It also has programs of Canva and Hootsuite embedded in that program to allow for more efficient marketing and a social media workflow. We've also adjusted and been focused on more mission-driven messaging. So really sitting down to learn more about organization-specific initiatives and then rephrasing and adjusting our messaging to match their goals and their needs. We've also tried to do direct asks. So when we have these presentations and things, replacing that, okay, I'll follow up with you in a couple of days or a couple of weeks to let's kind of put you on the spot and say, what would be a good day or a good week to schedule a visit? And we've had some success with it. So, and then lastly, we have offered AD visits on the spot while at conferences or when we have an exhibit booth. And we were able to get at least one visit so far. So it's still a work in progress. In terms of social media, we have tried LinkedIn ad campaigns. which has provided us the opportunity to set individual parameters that have led to increased exposure and what my social media leader tells me are impressions with social media, expanding beyond our direct connections. We also have new platforms, Threads, and Instagram for some of the younger folks out there. It's all new to me. And then we've also provided a greater variety of caption types, fact-based, polls, healthcare holidays, team events, things like that. What we've realized is that our most positive engagement and success has been with the team photos and video responses to our poll questions. People want to hear us and see us and be more interactive. And in fact, the American Diabetes Association shared one of our first Instagram stories and started following us. So our team was very thrilled and excited by that. And then we've also conducted pharmacy podcasts with our internal team and in conjunction with our partnerships. One of our biggest shifts in the areas that we are currently developing is readjusting our branding and marketing, reassessing what is our story and how are we going to tell it? How do we create effective messages that are simple, relatable, and repeatable across a team of 30 plus detailers? So through our research, we learned a distinction between branding and marketing, how customers feel about a product, and then how they are actually going to act on that product. We learned about the pillars of success, this concept of story brand, and this hero's journey. So through our research, we basically identifying customer wants, defining their challenges, and offering the tools that they can use for self-expression and resolution to that. I had an example here, but in the interest of time, I'm going to quickly go through it with Steve Jobs, who years ago did a multi-page ad, a bunch of technical specs, turned out to be a big flop. Nobody understood the complicated jargon, couldn't relate. 14 years later, a new approach, 2 words, think different. It was something that was more relatable. People could envision their personal goals, and more importantly, they believed that those goals were achievable. So for years, we've utilized an advanced-centric approach. What do we do? What are our features and services? So similar to what you were talking about earlier, Mike, shifting to a more customer-centric approach. The customer is the actual hero of the story, not our brand. So relating that to academic detailing, our fancy brochures that we created aren't the prize, but the relationship with the detailer is the prize, and detailers joining providers along their own journey. These are just some examples of our promotional materials that are still in the works. So getting back to a little bit more in terms of opioid safety, as we noted earlier, UIC received a grant to deliver REMS opioid education via academic detailing. The entire nation, and even the world, has been talking about combating the opioid epidemic for decades. So why are we still discussing it? Why does it still matter? A few points of interest are to reduce the stigma surrounding the cause of the opioid epidemic. Prescribers, treatment team, pharmacists, pharmacies have all been pegged as responsible for the cause, with each placing blame on each other. But ultimately, as healthcare providers, regardless of your discipline, we all play a role and share the same goal of providing consistency in treatment and quality care. There's also newer topics and legislation that can rejuvenate interest in opioids, in particular, naloxone, buprenorphine prescribing with the removal of the X waiver recently. So while treatment guidelines and therapy options have remained consistent, there's value in continuing this conversation on opioids in a reinvigorated way. And of course, that reinvigorated way is academic detailing. An opportunity for individualized, non-judgmental discussions. And our prescribers have talked to us and expressed enthusiasm about the value and appreciation of AD as a clinical resource. Some of these values you see listed here, improving prescribing practices, serving as a resource, and helping reduce stigma. This is both from a clinician and a patient perspective. So having those difficult conversations with our patients and with each other as clinicians, removing that blame game and kind of focusing on what our shared common goal is of patient care and safety. This is just some example of some of the behavior change goals through our academic detailing materials and educational materials. These are some of our clinical resources that we use to convey those messages. I do want to take a quick moment here to provide a brief summary of our REMS program successes thus far in terms of quantitative outcomes data. This is through the end of August. So on our winding road to infinity, AKA our very, very lofty goal of 1 million visits in 1 year. We've reached several states across the country, but we still have many states to go. And there are many in New England, hint, hint. Just again, some more outcomes data here. Through August, we've completed over 1,000 visits. Up to date, we're now over 1,200 visits. What I want to quickly highlight here is the completed learners, separated by those who have completed the core topic AD visits, plus the continuing education form versus just the visits alone. And taking it back, the takeaway here being the presumed value of CE, the learner versus the program perspective, the hero's journey, all of that, and what advanced perceived as the customer want versus what the customers truly wanted. They had more interest and worth in the education and relationship with the detailer than the free CE credit. This is just a list of some of the number of visits per topic. From a qualitative outcomes perspective, circling back again to the behavior change goals and hero's journey, as academic detailers, we aim to have some kind of lasting impact on the providers. So with the REMS program, we've tried to reach out to multiple providers and things, and fostering open communication, a culture, a stigma-free culture. And then also based on what the providers have expressed they wanted was providing information on destigmatizing conversations with patients, what are some strategies to facilitate that, and that academic detailing provides the opportunity to address some of these issues. These are just, again, some highlights here of what providers have said about AD visits being interactive, engaging, and building confidence in decision-making on opioid safety. Academic detailing can certainly impact providers and clinicians, but it also affects detailers. So while it has been beneficial and very important to expand AD services to other types of healthcare providers, it has proved to be one of our team's primary challenges with the REMS program. How do we learn to adapt our detailing approach for specific clinicians, utilizing the prescriber-centric materials for clinicians with limited prescribing authority, and essentially emphasizing tools and responsibilities, revisiting the hero's journey, and that pharmacists, nurses, et cetera, can have a specific type of connection and being able to modify the conversation, considering what actions can they most feasibly implement. Oh, I'm sorry. Wait a minute. Am I missing a slide here? Okay.
We are having a touch of a glitch with Pull Everywhere. I will be having a stern talk with it during lunch. So
okay. Okay, so which Paul's question here, which of the following would be a strong needs assessment question when detailing a community pharmacist? Focusing on one of the main components of an AD visit. This is what we're kind of talking about here. How would you adjust the detailing approach to your audience?
This feels like a quiz, Narissa.
You know, I like to keep people on their toes. All right. So, okay, we're getting some answers here. We all know with multiple choice questions, the correct answer is usually all of the above. So yes, D, I think, although answer C is probably the most common in a community pharmacy setting, but certainly all options are reasonable. And I want to quickly highlight here, everyone's voyage follows an individual path. So I encourage you to learn tips and strategies from the other programs here as well in the next couple of days, but still staying focused on your unique individual journey. That being said, some general best practices that we've learned with Illinois Advance: utilize strategies outside of the box. Every idea is worth a shot. So step out of the paint and attempt a three-pointer every once in a while. Clinicians are the purpose for academic detailing, and detailers are the method of delivery for that purpose. So actively listen to them. Navigating key messages and educational materials based on your audience. Basically, prepare for everything and be prepared for anything, as we all know. And then lastly, acknowledge and celebrate the small wins. Every basket contributes to the final score. Acknowledgement and celebration drive continued inspiration and fortitude. Simple gratitude and support to your team goes a long way. And setting these lofty goals and challenges that we apparently like to do at Illinois Advance and UIC is what challenges and motivates us to continue to be our absolute best. And one last thing here, this is just information on Illinois Advance, our QR code to our REMS program. And I thought it was very important to share. It's a shameless plug, but also a shout out to my colleague. We have an expert REMS opioid detailer live here at the Fairmont Copley. Dr. Shirag he's happy to create his own AD summit. I think he enjoys it a lot. So on that note,
Throw your hand up, Shirag, so we can, yay, good job hiking.
he said if I didn't get visits, I couldn't go back to Chicago if I didn't get visits while I was here, I couldn't go back to Chicago. So he offered his services.
Thank you, Narissa. All right. We have a question here from our very own Mike Fisher.
Oh boy.
Thanks, Narissa. That was great. I love the ambitious goals. 1 million visits in a year would be amazing to see. But even just the national scope, and it's fascinating to see that you're getting visits from all the different areas of the country, just but small numbers in each state so far. And I'm really curious. We talk a lot in our work about ways to help organizations not have to completely reinvent the wheel, that everybody doesn't have to generate content from scratch on topics that we know have a national impact. And so I can see why something like a REMS program that's a national risk evaluation mitigation program, that it would be appealing to do it nationally. But it's really hard to know the local context if you're reaching out to people in all those different states. And so to sort of break it down to sort of a more compact question, I guess I wonder if you could comment on, are there things that you think are especially hard about doing that nationally, where it feels like if you don't know the local context, it's just not connecting? Or on the other hand, are there elements that are more efficient nationally, where you feel like, because you're saying we're not just looking at one region, we're looking at the whole thing, so it makes it easier? Because that national model, when you're not in a closed system like the VA, is really novel.
I think in some respects, I don't want to say it's easy, but it's manageable because the topics that we cover are all related to opioid safety, naloxone, special populations, et cetera. So on a national level, a lot of that is very similar across the board, I think. Certainly where it becomes more challenging is when legislation comes into play with that. So the simplest example would be naloxone. I mean, most states do have the standing order and different liability coverage, things like that, but that also varies state to state. So being able to, as detailers, being able to do the preparation and the research beforehand, so if I'm going to do a presentation, if I'm going to do an academic detailing visit on naloxone, let me look into Oklahoma's laws on that, or into Connecticut, et cetera. And a lot of it, I think, becomes part of the preparation. Some of it, too, is just when you're having that one-on-one conversation with the provider, simply ask them, hey, we're going to talk about naloxone on a global level, but what's particular in your state or in your region? Because even within a state, you have urban versus rural, things like that. So talking to the provider during the needs assessment and just even throughout, because you can learn from each other ultimately, I think.
Thank you, NaRCA. We have another audience question.
Thank you. This was a lot of information, and you have an extremely robust, heavily staffed program, which is outstanding. You use a variety of modalities to reach into getting the information out there. How would you streamline it, and what would be your favorite things to streamline for smaller programs that are much more rural based and don't have the pull that you do with the Illinois Advanced?
Modalities in terms of what, like
Information, like the different platforms you use.
oh, like social media and marketing and et cetera. Okay. Yes. Well, I think what we have also tried to do more recently, I can speak to this in terms of our marketing project, is doing the research again on what's going on in Sangamon County, which is central Illinois, which, they don't have near the amount of resources that we do in Chicago, and finding out what are some of their initiatives, what are some of their particular needs and things, and reaching out on that level, I guess. Really trying to individualize it. I mean, yes, we have this very sort of global, if you will, perspective and how we do things, but we really do. We do actually have the luxury as well of having a couple staff in central Illinois who can do the outreach down south. And they have told us it is very different when they have to do, whether it's email outreach, in person, cold call outreach. So it's just adjusting the approach that they take with it. Because what I say to providers in Chicago is going to be different to how they approach it when they're down there in Springfield or central Illinois. In terms of social media, I mean, I'm new to that too, to be honest. So I think it's also, again, okay, if they don't have social media accounts or maybe Wi-Fi and internet and all of that isn't the easiest resource available to them, maybe we do just go call them and go to them in person and market the similar messages in a different modality.
It sounds like diversifying your approach and asking local communities what they need and doing a bit of that groundwork and investigative work and figuring out how you can do that within a budget is one way to approach it. A round of applause for NaRCA. Thank you so much. I would love to know who is the person who said, let's do 1 million visits. It was your boss. Okay. If you're watching now, no, I'm kidding. We have some time at the end of this session to talk more broadly about stigma as well. So please do squirrel away those questions. But I'm now going to ask my co-pilot, Vishal, to come introduce our final presenter for this segment. Thanks, guys.
All righty. I am very excited to present our next speaker. Oh, I cannot talk today. There we go. I'd like to introduce Dr. Brandon Misrock from the Utah Mountain West AIDS Education and Training Center, or AETC. We've had the pleasure of working together on a lot of PrEP-related initiatives or pre-exposure prophylaxis. Does absolutely phenomenal work, has such a wealth of experience, and we could not be more excited to have him up here presenting. So without further ado, Dr. Misrock, Brandon, please come on up.
So thank you everyone for coming today. I am so excited to be here presenting at the NaRCAD annual conference. I feel like all the presentations before this have been so academically rigorous. Mine is more about vibes. So feel free to put your brains into low power mode until lunch. But hopefully I can help talk about stigma and the work that I've done. So yes, my name is Dr. Brandon Misrock. I don't have any disclosures or anything any conflicts of interest to talk about today. And I thought I would talk or begin my presentation with really just kind of talking about my career, talking about what led me here in the process of it all. So after graduating from medical school back in 2017, I decided to pivot into public health. And that's where I found the Louisiana Department of Health. At the time, I was living in New Orleans, Louisiana, and started there in late 2017. Pretty quickly after that, I was actually informed about this amazing organization called NaRCAD that does this talk on the exact thing that I was trying to do, which is academic detailing. And I attended the first ever prep symposium back in early 2018. Fun fact about that. So at that point, I started really with my academic detailing program there, talking just about prep. So if you go to the NaRCAD website, you'll actually see this picture on the About Me. I know, right? Oh, yeah, no, you took that picture. That's so fun. Yes, this brings me way back. Fun story about this. I remember vividly this experience because I was doing our mock session where we were trying to practice academic detailing for the first time. And I believe the sentence I was trying to say was, "Oh, I'm here to talk to you about how you discuss sex with your patients." And instead, I believe I said, "I'm here to talk to you about sex with your patients." And yes, big laugh that time too. But yes, I just kind of want to emphasize that you can start from really humble beginnings with this work. Moving on. So from there, I really learned everything that I pretty much still do to this day from that first session. And I was very fortunate that at the same time, our program began to expand. So at the time, I was working for the Louisiana Department of Health, Office of STDs, HIV, and Hepatitis. And we decided to expand the program. So instead of just detailing on PrEP, I started to also talk about and do presentations on topics like PEP, syphilis, and congenital syphilis, and eventually hepatitis C. In 2019, the Louisiana Department of Health launched the nation's first hepatitis C elimination program. I was so proud of this event. It was a massive undertaking, really aiming to help eliminate hepatitis C in the state. And quite frankly, we had scores and really hundreds and hundreds of doctors that have never treated hepatitis before and needed to learn about this topic to be able to implement our goal. And so from there, I was essentially tasked with creating the entire educational curriculum that we were doing for the state on it all. Again, just kind of being thrown into the deep end and using a lot of resources that I found working with colleagues around the state. But I am so proud of the work that we were able to do. So many different things came out of this project, but one of the biggest ones were the 2 Project Echo series that we did. Actually, they are still running today. And this champions training program that was a really intensive 4-hour lecture or series conference that we would do that would essentially walk a provider through everything they would need to know to start treating hepatitis C. When I left, we had cured almost 11,000 people of hepatitis C, and that is something that I will always be able to hang my hat on as being something I'm very proud of. Thank you. Thank you. So from there, in October of last year, almost exactly a year ago, I moved from Louisiana to Salt Lake City to take over the AIDS Education Training Center there. For those of you who don't know, the AETC is a national program, essentially a detailing program funded by the federal government in each state. And I help run the one that we have in Utah. And when I say help run, it's really just me and another guy kind of doing all of it. I know that a lot of detailing programs across the country look like that, and that is a totally acceptable model for all of us to have. So my program is half supported by the Utah Department of Health and Human Services. That's what makes it slightly unique, that I'm both AETC and Utah HHS. But I'm very happy with the work that we've been able to do. In fact, slight plug, we have a new Project Echo series that I'm going to be running starting in January called Elevate Love. Love is LGBTQIA plus oriented virtual education. I know, right? It's such a forced acronym, but the elevated part on there is that's the slogan on our license plates. I think it's the state motto in some ways is life elevated. So now I wanted to do love elevated. Yeah. Anyway, again, our program is a small one, but I'm very happy with the work that we do. We're able to really kind of get the word out and change a lot of hearts and minds, especially with this Mountain West Transforming Care Conference. For those of you who don't know, obviously there's a slew of these laws kind of across the country now, but Utah was one of the first states to start passing these anti-trans legislation laws. And we were very happy to be able to kind of help combat that with this very large conference that we put on now every year. Specifically focused on trans healthcare and trans rights in the medical community across the state. This is me and my colleague who run the ATC. Again, humble beginnings can really do a lot when it comes to that. So, what am I here to talk about today? Stigma. Stigma is obviously something that is a very wide topic, and I'm very interested to hear from you all about some of the language that you might have heard in detailing, in going to the doctor, in talking to your friends who've just returned from the doctor. I'm curious to hear about some stigmatizing language that you might have heard. So for everyone here on the, what do you call this? Poll everywhere. There you go. Feel free to fill that in. Oh yeah, addicts, cross-dresser, those people, that is a very big one. Addicts. I love that we don't see those type of people. I'll get to that in just a bit. Oh yeah, patients don't want to help themselves. They just want a pill for everything. Again, these are exactly the kinds of things that I hear all the time in the work that I do. And I'm sure everyone in this room could understand how dehumanizing this is, how much this would make someone less likely to want to be able to seek out care. I mean, honestly, I detail on topics that are very highly stigmatized in our society. Just again, that I've mentioned before, HIV, STIs, hepatitis C. We're talking about conditions that tend to affect people that are often the most marginalized in our societies. And terminology like this, words like this can really have a huge impact on what we're doing. And as a result of that, here we go. Well, maybe I did lose a slide there. Either way, what I was trying to say was it's really important that people understand that we're trying to fight that, because provider stigma is one of the biggest barriers to all of the collective missions that we're trying to accomplish. And there's a lot of different ways to diffuse that, to kind of cut through that. And that's really what I'm here to talk about today. So I'm just going to try to offer up some advice for people who may be new with this detailing thing, people who want to kind of redefine their programs, people who might be running into these sort of issues and want suggestions on how this random guy potentially overcame that. Again, I'm very interested. I have an interesting career in the sense that I have practiced now in two unbelievably different places. I like to joke that I can't think of two more opposite cities in America than New Orleans and Salt Lake City. But being said, there's definitely some lessons to learn from them. So overcoming stigma. Again, this is essentially when you as a detailer are trying to work with a clinician, let's say you're even doing a cold call and just going to a place for the first time, and you are trying to get them to talk about a topic like PrEP or hepatitis C or any of the other topics that we've heard about today. Some providers are going to come at you sideways in a couple different ways. So I've broken it down here into some of the things that hopefully I can talk about. So overcoming stigma, this aggressive versus avoidant. Sometimes I like to characterize individuals this way. Sometimes they'll be pretty in your face with the fact that they do not want to talk to you. I do not want to give my patients permission to have unprotected sex. That, again, is something that I hear all the time when talking about PrEP. I love this notion that, like, we give our patients permission to do the things that they do. Like, you know, we have some sort of prescription pad for sex or something along those lines. And essentially, how would you approach that? So I like to think of kind of these sort of psychological judo moves, or other ways to think about it is like how you would deal with a fussy toddler, and how to potentially redirect them in that way. And that's really what I'm talking about here. First, acknowledging their concern. Again, oh my God, whatever sort of hateful, prejudicial thing that they sometimes say, you have to acknowledge that and kind of try to move forward with it. So in this instance, I'm talking about, I know it's so frustrating sometimes. I appreciate you want your patients to be as healthy as possible. Again, please take note that I didn't agree with him in any way, shape, or form. This is something that actually did happen to me several times, especially in my work in Louisiana. And yes, but then you can switch them over to a different topic. So essentially trying to acknowledge, listen to what they said. Our last speaker spoke pretty greatly about the importance of active listening in this, and that is so crucial to everything that we're talking about. But again, going back to prep involves frequent visits to be tested so you can cure any infections before they have a chance to spread, reminding them of the larger goals. Again, you don't need to battle every sort of nitty-gritty point, but trying to find that common ground that you're both working towards is huge in overcoming these sort of barriers. Sometimes, though, you'll have providers that aren't as upfront with what they do or do not want to talk about with them. I like to call those the avoidant type in what you're doing. So this was something that came up hugely in the poll everywhere conversation that we were seeing. Oh, we don't have those kinds of patients here, or oh, we don't treat those patients, or that sort of a thing. Again, always sort of an impressive statistic to me in the sense that, you don't get to choose your patients at a practice. They essentially just kind of come to you, and just think that your clinic would somehow be completely immune to the demographics and statistics of any sort of society is funny. Like, oh, sure, none of your patients have ever used drugs, or none of your patients have ever had sex. Of course, you're the one exception to that. But again, that's not what I'm really trying to say here. That's more of my internal monologue when I'm dealing with situations like this. Instead, I like to kind of remind them that we're taking a community approach to things. So this is actually one of the things that came out in the new 2021 guidelines for STIs that the CDC put out. Again, I talk a lot about STIs, so that's mainly what I'm focusing on here. But taking this community approach, taking some of the lessons that we learned during the COVID pandemic and trying to apply that, essentially casting a wider net when it comes to testing, and trying to make sure that we are treating people as not just the individual, but as part of a chain in a communicable disease transmission. So how do we break that chain of transmission? Again, things like, it sounds like you really value your patients here, or it seems like you have a lot of respect for your patients here. But the CDC is asking all doctors to talk to their patients about PrEP now, regardless. Again, learning more about these topics, learning what you are trying to say to your audience is really how you're going to get that message across in terms of how do you change their behaviors. Again, I guess that's the entire point of academic detailing, is taking thought and practice into behavior change. So again, these sort of guideline stipulations I have found to be very helpful, especially for people who are saying, oh, we don't do that here. So yeah, things to think about. Again, another point to talk about is this is U equals U. Apply that to your prep. Apply this status neutral approach when it comes to HIV in any sense. There are so many, any topic that you are detailing on, any topic that you're really working with, you can find grander sort of lessons that you can apply to it. And also remembering that everything that we're talking about is interconnected. So there's always a different framework that you can approach these things from if you feel like you're getting these sort of resistances. So, oh, perfect. The last one that I really want to talk about with everyone today is this last one, which is, what do you do when you're overcoming the stigma of people that are just topic-based? Essentially, we don't do that sort of thing here. I don't want to talk about that. I don't do that with my patients. This topic is kind of a non-starter for me in so many ways. Sometimes you'll see that with individuals in primary care when we'll say, oh, that's a specialist sort of a thing. Especially when it comes to PrEP, that's probably my biggest pet peeve is primary care doctors saying, oh no, PrEP is an ID doc thing, even though the entire point of it is to prevent that appointment from happening. But you'd be surprised how big regional differences can impact everything. So again, I'm talking about a lot of detailing work I did in New Orleans, and now I live in Salt Lake City. There's a very large divide about what clinicians, about what the general sort of consciousness people think about certain topics. Louisiana, sexual health, STIs were very openly talked about. It's the big easy, laissez le bon temps and all that. It's very much was not a big problem. But drug use, talking about drug use, talking about opioids, talking about harm reduction, those were very big hot button topics. People essentially slamming the phone down if you tried to talk to them about it. Sometimes you can get pretty aggressive pushback. Utah, interestingly enough, exact opposite issue with all of it. They have no problems, no qualms, again, in my own personal experience, talking about drug use, talking about that sort of thing. But sex in every single way is highly stigmatized. And again, you can find ways to sort of overcome those. And one of the best ways, especially when dealing with topics like this, I have found is to take what I like to call the syndemic approach to detailing. Again, like I was just saying before, none of these conditions, none of our patients, nothing exists in a vacuum. It's all interdependent. It's all interconnected with other things. So STIs, HIV, hepatitis C, those are perfectly synergized sort of conditions in the terms that there's a lot of overlap between risk factors, about the potential populations that would be at the highest risk, all of those sort of things. So being able to talk about multiple different topics, being a detailer that can lecture on more than just one subject becomes very crucial to this. So PrEP, PEP, STI treatment guidelines, sexual history taking, HCV, these are all just a few of the things that I talk about. So if I get pushback on one topic, I say, you know what, that's okay. Would you like to hear about DoxyPEP? This is a brand new thing that the FDA is really putting out there right now. And again, just kind of like with children, if you're not getting a good response to one thing, maybe try to focus their attention in a different area and see if you get progress with that. But again, it's very important that even if you are getting resistance, knowing other topics, being able to discuss these different things is so crucial, because all of these illnesses, conditions, topics that we're talking about are all highly interconnected with each other. Excuse me. So multi-topic detailing always ensures you'll have some sort of common ground, but it's more than that. It's about being able to foster that long-term relationship. If you are detailing on multiple topics, you are every time that you see that provider, you can reinforce what you talked about at the last session, as well as you are getting them psyched up, hyped up about a new topic, reinvigorating that passion. We talked a lot about burnout and a lot about stress and whatnot, and I have found that hope in any sort of its forms is one of the biggest things to combat that feeling. And the most successful detailing results come from multiple interactions. Again, having multiple sessions with the same provider, having feedback sessions where afterwards they tell you if something worked or didn't, or sometimes I get calls that are just, Brandon, is this clinically right? I wanted to make sure that I'm doing right by my patients. Having that ability where they can just shoot me a text message or a phone call quickly is very helpful in building that trust. The final thing I'm just going to talk about is language. Again, trying to remind people that we are there to help them, that we are a resource, not an extra chore that they have to do, not an extra thing on their to-do list for everything. So if a provider doesn't know a lot about a topic, they're going to have a very large gap in their ability to discuss something. They're not going to have the language that they need. And that in and of itself is enough reason for them not to want to proceed further with a topic, not to want to talk to their patients about it, because God forbid they get a follow-up question, or God forbid they don't know how to properly discuss something. That's the sort of resources that we can provide. Treatment algorithms, language guides, ongoing support, like I was just talking about, are so helpful for all of this. So because I am out of time, I want to be able to give you the key takeaways for all of this. So
Brandon, you have another 2 minutes. You're good.
Oh, okay. My bad. Well, then let me back up a little bit. There you go. So I think the best way to start with all of these sort of things on any sort of stigmatized topic that you might be dealing is becoming comfortable yourself with it. You really are going to set the tone for the conversations that you're having. You're going to set the tone for a lot of the discussions that your providers will be having with their patients. So getting comfortable with yourself, being able to say the words like sex, like drug use, like, whatever it might be without kind of looking down and feeling awkward, because again, that telegraphs a lot of what's going to happen in the interactions that will be further on, can go a very long way. The more comfortable you are, the more comfortable you make them feel about being able to have these sort of conversations. And again, set that model for them to be able to move forward. Focus on the shared interest that you have. Again, the worst thing that you can do when facing resistance from people that you're trying to work with is to try and refute point by point, going back and forth, because it creates an adversarial relationship between you. And again, that's not what we're trying to do. Instead, try to just say, what is the larger goal that we're trying to treat? I mean, at the end of the day, it's always going to be improving patient healthcare, improving health outcomes, reducing health inequities, those sort of things that people can get behind. Try to focus on those if you're getting resistance. Active listening is so crucial to this process. Mirroring back their language, again, having that sort of conversation with them. Motivational interviewing is a fantastic topic that is very much in line with everything that I'm saying. If you want to learn more about that, I highly encourage you to look up research around that. And the last thing is try to inspire. Again, I know that we've talked about this a lot, and it was even kind of one of the points of the lectures today, but try to be that beacon that they're looking for. So many providers are so burnt out these days, are so at the end of their rope. And again, the idea of trying to add something else to their patient workload, something else to what they have to remember in the 10 minutes that they have with their patients can be very difficult, but you can inspire them. You can help what am I trying to say? You can help motivate them, energize them to want to make the changes to their practice that we're trying to encourage. A lot of the best ways to do this are, number one, try to find a way to humanize a topic. So for instance, with hepatitis C, one of the biggest things that we saw, especially when we were first treating it, was how many patients would break down and cry and hug their doctors when they said they were approved for treatment. I mean, again, it is such a hugely inspirational thing to think of an illness that a primary care provider can not just treat, but cure. I mean, that is something that almost never happens in modern medicine, that you have an illness that will eventually lead to very terrible health sequelae, but we can cure it right now and prevent any of that from happening. That's huge. And connecting your topic to a larger public health goal. I mean, if we're talking about health inequities, we see a massive difference in the uptake of Caucasian individuals versus people of color when it comes to PrEP. So if we can talk about addressing racial inequities through the lens of PrEP, that can be a great way to connect with someone and help inspire them to want to do this sort of work. You know, again, I'm trying to speak as broadly as possible so it can apply to everything, but if you all have specific questions, I'd be very happy to address that as well. But that is really what I'm saying with all of that. Try to find a way to connect with the doctors and other individuals that we're working with to get our message across and kind of cut through the BS along the way. So that's really what I have for you all today. Thank you so much.
Thank you, Brandon. All right. Well, we have some time for questions for Brandon, but in the meantime, I'd like to call Trish and NaRCA back up here and make sure that they can share a mic between them. Brandon, I'm going to switch spots so I can keep my eye on the Zoom chat, and I'm going to give you this. Perfect.
All right. Well, NaRCA and Trish are getting settled in up here. Please do think of any of your questions, either for specific folks or if you have a question more generally about academic detailing related to stigmatizing topics and having these conversations with clinicians in general that we might throw out to any of these speakers. Before we kind of take a team approach, Brandon, we have a question for you from someone in the live stream chat named Daniel Daniel Sledge. So Daniel asks, when you're, approaching these specific topics that you have detailed on and built programming around, where do you think motivational interviewing fits in terms of leaning towards kind of meeting them where they're at? And what techniques or recommendations regarding motivational interviewing would you make for new detailers who are working on topics like that?
That is a great question. And I apologize for just breezing by motivational interviewing. Again, in its simplest form, it's kind of a step-by-step incremental approach to change. So a great thing to start with is if a provider seems wary about something like PrEP or PEP, I can get them to talk about taking a comprehensive sexual history. I mean, obviously that is something that is crucial to medicine, history taking and all of that. And just, these are ways that you can ask specific questions of your patient. These are important information that you want to get out of it. And that would be essentially my first step. From there, I can usually use that as a springboard to get them more interested in something like PrEP or DoxyPEP or what have you when it comes to that. So for me, motivational interviewing is more about if my goal is PrEP or whatever topic I'm trying to detail about, and I can't necessarily get there, starting with a half approach, starting with something that is a little bit more, a stepping stone on the way to there, I have found it very helpful.
Excellent. Thank you. I would actually love to open it up to folks here. We have a question from Mike.
This is thank you all three of you for great presentations. I think thinking about these different areas and the different ways in which stigma can manifest, whether it's around sexual health, whether it's around substance use disorders, around anxiety, depression, each is different, but that underlying theme is so important. And so I'm curious for each of you, sort of reflections on when the detailer, when detailers and detailing programs are either preparing your campaign overall if you're a program, or preparing to go in for a visit if you're an individual detailer, and you're saying this is a topic where there's a lot of stigma. Do you bring, your thoughts or firsthand experience, if you've done it, on sort of bringing that up preemptively, it's having a sort of preamble, this is a topic where there's a lot of challenges or stigma or something like that, versus sort of having all that in your back pocket and sort of, wait and see what they say. But then, are you worried about kind of being on the back foot if they've sort of, come at you with all that? And running them through in my head, I could imagine either way going great or going poorly. And I'm curious about your experiences of leading with this as a stigmatized topic or keeping some of that in reserve to use when you need to.
Let's throw that to Trish to start, kind of go in order. Yeah, great question. Do you sort of approach the elephant in the room and put it right out there, or do you wait?
I wish I had just one answer to that question, but I think the simplest answer is that we try to be flexible based on our knowledge of that clinician. So if we're lucky enough to have a previous relationship, we can gauge a little bit how we might like to open. If we don't, I love that when we train for our topics, we always have a number of openers in our back pocket. And we usually try to gauge when we go to if we're lucky enough to go in person, what's going on in that office, alluding to the earlier question around how do you make folks more comfortable around stigmatized topics? Are there posters in the waiting room? What kind of vibe do you get from this place? You get the sense that they're pretty comfortable talking about stigmatized topics. And you also have to consider your own internal biases. What am I bringing into this interaction? Do I have a preconceived idea about this practitioner? Maybe there are no posters, but maybe that person is fully aware and informed of all the different contexts a person can be in. So we try to play it a bit by ear, but definitely have that in our back pocket for a needs assessment.
I love that piece around also looking at your own potential implicit biases, right? Because we all have them. And similarly to, not expecting clinicians to be perfect, we can't expect that of ourselves and need to know what's going on in that internal landscape. NaRCA, what would you say about that? Do you try to get ahead of it with a topic like opioid use disorder?
So I would say, kind of going off of Trish, similarly, our team tries to be flexible and go off of the clinician and trying to read the room, if you will. I think also because we have such a large team, we also have a large variety of personalities. So the approach that they take will depend kind of on the detailer as well. We certainly have some staff who, they see the elephant in the room as a little puppy in the room, right? And then some who are a little more hesitant, and let me get a feel for the provider, and then I'll kind of go that way. So I think it's kind of a mix of the flexibility of the provider, but also the flexibility within the individual staff that we have.
Awesome. And Brandon, let's round this out. How do you personally approach that? Do you dive right in?
Honestly, yeah, that's typically been my approach to things. If you can't tell just from the way that I talk, I'm a little bit more gung ho about stuff and shooting from the hip. But no, I typically, like Mike was saying, I keep counter arguments, counter proposals, whatnot in my back pocket. Is typically the approach that I have found to work best. Again, I think it's very different based on exactly who you are as a detailer and exactly what topic you're trying to discuss that day. But being able to have not counter arguments, but being able to have something that I can kind of come back with in reserve is typically my approach for all this stuff.
Lovely. You caught yourself because I was about to say, you said you weren't arguing.
I know. And that's actually what I was trying to catch myself. So again, it's not about like, no, you're wrong. PrEP is good, but it's more about like, oh, well, I'm sorry that you feel that way. Let's talk about this instead. Sort of, that's my counter proposal. That's in my back pocket.
Great. Do we have questions from the audience here? We had a live stream question, so now we can go ahead and bring it back over to the left-hand corner, and then we'll get there. Oh, and then we'll get you. So we'll do over here, and then we'll go to Jonathan.
They've been waiting.
Oh, you've been waiting. Go right ahead. Thank you.
Yeah, either way, I had a couple of questions, but I think it's really exciting to hear about the emergence of social media and a couple of your approaches. Maybe just to start with Brandon first about some maybe vision about integration of social media and kind of non-traditional communication across in Park City, Utah. And I know it's an incredibly challenging and dynamic geography as well as cultural differences. And it'd be great to hear about your visions and maybe some integration of that. And then also NaRCA, if you could maybe touch on outcomes and knowing, how do you know that your social media is working? So if we have time for both, that'd be awesome.
Sure. Let's start with Brandon.
Yeah. So essentially your question was, how do you utilize social media for outreach purposes? No, that's a great question. Honestly, I don't have a science behind it. I have a pretty random Twitter account that I use to kind of just voice my musings as well as promote any sort of like educational events that are coming up. I have found that actually works surprisingly well. Social media has been a fantastic proponent for finding and recruiting speakers for our Project Echo series, for those sort of events. Reaching out to people that way, I found to be unbelievably helpful, especially also for identifying people that are doing cutting edge research in fields like addiction or HIV care or what have you. Yes. That is my main approach to social media, but I don't think there's a right or wrong answer. I'm very interested to see what you have to say.
Sure. No, absolutely. Yes. I think in terms of utilizing social media, some of the different strategies that we have utilized is, yes, it's networking. People know people. Everybody knows somebody else. But also when we are reaching out to someone like an organization or a provider, sending these direct messages that you can do through, again, this is all new for me, but sending direct messages through like LinkedIn, for example, and using, again, that sort of mission-driven messaging. So looking at their website, finding out about what are their goals and what do we at Illinois Advance have that relates to those goals and those missions and things. To your question on outcomes, ultimately, if you're going to ask upper management, does social media get us an AD visit? So there's been minimal success with that, but it is something we're continuing to do. If you ask our team and our social media leaders and things, getting the brand, getting the name out there, not just Illinois Advance, but academic detailing and what this is as a resource. That we have all these different available resources as well. Getting them to follow us on social media, reshare our stories, things of that nature, that exposure and increased connection.
So you're talking about visits gained, which is difficult to look at as causation versus potential correlation, right? But then it sounds like looking at engagement stats and seeing that visibility is clearly going up is another great way to do that. And for those of you who are just thinking about starting this kind of social media, kind of dipping your feet in, we have a great resource online that you can check out. So come talk to me, and we'll also make sure that we get it out to you in our resource list at the end of the conference. All right, over to you, Mariah. I know you have somebody who has a comment.
Hi. So as a fellow Utahn, I can say Brandon speaks the truth. But the main question I have for you guys is that I work with opioids in the PDMP for Utah, and we're watching the opioid crisis really change and evolve, right? And then providers want to know specifics on like, okay, exactly how can I do this? How can I do this in my practice? And I can't speak for other academic detailers, but I don't have an MD or a DO attached to my name. How do you make yourself a qualified and accredited person to be giving this information where they trust you as a source?
Great question. And just to repeat for the live streamers, how as a non-clinician do you have credibility? That's great. I'm going to throw that to Trish, actually.
Sure. Thanks. It's a fantastic question. It's one that we encounter in our small service as well. Even though we are, most of us are pharmacists, we find the situation of going into a doctor's office and talking to them about drugs and diseases. How do we get that credibility? And what we do is we rely on our training process and our advisors to give us that sense of credibility around the topic. So we don't come in there pretending to be on, at the same professional certification as them, but we do come in and say, we've had the luxury to have the time and the resources and the advisors to dive deep into the evidence and the guidelines and the clinical information on this topic. And so we're coming to you as someone who is a topic expert who's been trained by physicians with a specialized practice, actively practicing family physicians, nursing, patients, caregivers. We've got this whole team behind us. So I'm one person, but I'm coming to you with the experience of many who have high levels of expertise in this area. And I'm here to provide this information, to discuss with you, to share resources. And I have confidence in myself because I've been trained through this rigorous process. I have confidence in our team who goes through the evidence, who identifies barriers and enablers. And I have confidence in the value of the information I can provide to you because of the expertise of our team. So that's sort of how we approach it.
Thank you so much, Trish. And again, we can talk a little bit more about things like bolstering confidence, especially if you don't have a clinical degree. And I just want to do a little push for our colleague, Jess Allard, throw your hand up, who is actually doing a presentation on this very topic. She's an incredible detailer without a clinical degree, and she's actually has a theater background. And let me tell you, that is a really cool thing that we could talk about for ages. How do you communicate? And so we'll talk more a little bit about that. And if you want to chat with our team, please do. I want to wrap us up with a question for all three of you. So thinking about stigma and the breadth of topics that you're covering, there are so many more topics that, even looking at diabetes, anything around, chronic diseases where things like nutrition are a component, or exercise. Stigma is something that I said before is obviously not avoidable, but it is addressable, and really looking at ways to empower clinicians to in turn empower their patients to come in and have these conversations and not feel like the clinician doesn't understand them or will dehumanize them. There's a lot of great literature out there, but just talking to these guys from being boots on the ground, I'd like to ask each of you, if there was one thing that you wish clinicians would adopt, not in terms of just a key message of, for instance, prescribing PrEP, but something around how they see patients in relation to the topic that you guys have been talking about, each of you. What's the one thing that you would wish that they would be able to adopt more broadly that is inclusive in thinking about that topic for their patients? So Brandon, can I start with you?
Sure.
And you can choose any of the subtopics, maybe pick one of them, because I know you have a broad range.
No, again, you can see the wheels turning. Honestly, I would probably say that adopting person first language. You know, if I had to choose one, obviously and I kind of say that in a larger sense because so many people in our society, a single stigmatizing medical encounter, a single bad encounter with a provider can make them kind of swear off healthcare altogether, can make them just throw up their hands and say, screw it, it's not worth it, because there's nothing worse than that feeling of feeling dehumanized, especially when you're already in the vulnerable state of being a patient, of having to come to someone else, maybe a stranger, with whatever sort of deep issue that you're having, for them to then say terms like addict or junkie or what have you, at that moment can just shut people down. And that can go on for years and years and years, that single bad encounter. So if you can prevent one of those, that's a life change right there.
Thank you, Brandon. And that applies across any topic. And we have some shout outs from the audience live stream saying yes. NaRCA, what about for you? What's one thing that you would say to do in terms of, this question?
Sure. I would say empathy, having more of that and understanding where understanding the patient perspective, where they're coming from. Everybody's story is different. Everybody presents their story differently as well. And I think just being more empathic and understanding that, and being able to, at least from what I've gathered, as prescribers or clinicians, we're focused on, okay, let me reduce that number of X, less opioid prescriptions, less MME, more naloxone, et cetera. But really trying to not quite focus on that as much and more understanding the patient perspective.
Excellent. Trish, let's round it out.
So I think some of this can seem daunting to providers. We're all gaining comfort with the idea of person-first language, trauma-informed care, empathy. These are all such great things to be doing. And I think that for providers, they want to be there, but they feel a little bit intimidated. And so the thing I'd want them to do is just not be afraid to try and to recognize that it's going to feel awkward when you first start doing this. You may make some mistakes, but I think people can perceive the spirit in which it's intended. And if you come across as genuinely wanting to be open, accepting, and to help, that the patient will feel that and they'll appreciate it. And you'll feel your way there from there. So.
Excellent. And that makes me think of the quote, if you're not uncomfortable, you're not listening. So with that in mind, big round of applause for these guys. All right, I have an announcement, and then we are going to move into lunch. The announcement sounds scarier than it is, which is that for those of you who used credit cards to authorize your rooms for the hotel, it may look like you were charged, but it is being refunded. It is an error. If you have any issues, you can talk to me, but I just wanted to warn you after we had one person say they saw something on their credit card account. I have been told that everything is okay. I promise we are not money laundering. But again, if we needed to, we would do it here for the fancy lunch that you're all about to go enjoy. So please stretch. Thank you for a wonderful morning session and take a load off at lunch. We'll see you in the afternoon and we will have breakout sessions after lunch. Here are the locations. So come on back and see which one you want to go to. And there are descriptions in the program book. Thank you, guys. up in 1 minute. So get yourself some coffee or whatever you need. Settle back in, and we are going to cruise right through the last session of the day in just a moment. All right, we're going to start back up. All right, throw your hand up if your breakout left you with a nugget you're thinking about. Yes, some nuggets. All right. Well, if you want to share what nuggets you have been thinking about at the reception tonight, we would love you to do that. Or if you just don't want to talk about work, we also recommend that. But hopefully you'll join us from 5 to 6. I just checked out the room. It is super cute and very New Englandy. So come check it out. It's an open bar and lots of nice little snackies and just a chance before you go grab dinner to connect with each other a bit more. But that in mind, we are going to move through a little more work. So I'm going to introduce you to our afternoon plenary. We've had so much of an increase of programs working on harm reduction. And this is really fascinating, especially in the substance use disorder space. About 5 or 6 years ago, when we were first connecting with the CDC after they released their 2016 guidelines on opioid safety, the focus was really about prescribing. It was really about what the clinician could do that was in their own hands, within their own wheelhouse. But as we all know, the opioid crisis and many substance use disorders are not necessarily about clinicians giving people a substance. Right. And so we have a lot of fentanyl out there, xylazine, just all of these different ways that folks are using substances that, are causing them harm, and they may have a use disorder. So 2 of these presentations are going to be talking about the ways in which reducing harm, right, is the way that approaching use disorder is being looked at, especially as the CDC has revised their guidelines and are starting to look at harm reduction themselves. And so one thing we'd ask you to think about as we get ready to jump into this plenary is harm reduction in general. A lot of times when we say harm reduction, we do think about very specific clinical topics, very specific disease states or situations. I'm thinking up north, Jess, who hails from New Hampshire, the live free or die state, right? Harm reduction being putting on your seatbelt, and some folks saying like, well, you can't tell me what to do. But what we're thinking about here is what are the things that not only you can do, but what are the things that clinicians can say to all of us as patients that might take the risk of harm down even just a little bit. Right. So the idea here is just a little bit of harm reduction, or a lot if possible, can make a really big difference rather than looking at things in a very black or white way. So with that in mind, I'm going to pop you back to Poll Everywhere. If you're not connected anymore, you can look up at the top here about how to reconnect via text. The question I have here for you is, what's one thing your primary care doctor could recommend to you to reduce harm and increase safety in your life? All right, I see appropriate monitoring. I'm not sure who said that, but if you're in the room or if you're here via live stream and you want to elaborate in the chat box, please do. Immunizations, yes. More sleep. Yes, we can all use a little more sleep. Following up on time. Oh, following up on time. Gotcha. Taking time for self-care. HIV PrEP. Yes. Anything preventive. Regular visits. Yeah. Staying on top of your care, right? Not waiting until something is amiss. Alternative therapies, exercise, bike helmets. Yes, I'm such a big proponent of that. What else? Couple more things. Move more. Yes, that's a nice way of saying exercise. Open conversations, whole health, mindfulness. Yes, all just taking harm, reducing it, getting us to a place where we can be closer to health. And again, looking at things across a spectrum. So again, for instance, with use disorder, instead of saying, well, I can't stop somebody from using, or I didn't prescribe these drugs, for a clinician to be able to say, hey, if I can get somebody who has use disorder, to a safe injection site, that reduces their likelihood of acquiring an infectious disease through intravenous drug use. So things like that. Couple more here. Eat less sugar, mental health check-in, food therapy, naps, home visits. You guys have great ideas. So what we're going to do is pass the mic here over to Darla Peterson, and I will let Vishal introduce her, and you guys will be in for a treat for these next 3 presentations. Thanks so much.
All righty. Good afternoon, everybody. We hope everyone's been having a great afternoon so far, and get ready for some more wonderful discussions. I'd like to call up and introduce Darla Peterson, the Regional Health Specialist with the Iowa Department of Health and Human Services, Division of Public Health, working in HIV, STI, and viral hepatitis through the Capacity Extension Program, bringing years of experience and some wonderful work working with providers throughout rural Iowa. And we could not be more excited to hear about these experiences. So I'd love to call Darla up for our next talk. Let's hear it for Darla.
Well, hello, everybody. I'm a little bit shorter. Thank you for the introduction. There I am. I have no financial disclosures or conflicts of interest, so we'll just get going. Here's some of the objectives that we're going to talk about. We'll talk about the benefits of collaborating and initiating those partnerships, and I'll help you identify ways to avoid duplication if you find out there's some cross-sector work in your communities. We'll explore some opportunities for co-presentations. We don't always do one-on-one AD in Iowa. And then talk about the cross-section of disease states, and that's really what influenced a lot of our work with collaboration. This is our regional health center map, regional health specialist map. We call academic detailers RHS in Iowa, regional health specialists. And there's 5 of us in the state, and 3 of the other ones are right over there, and 1 is live virtually. And I am Region 1, and so I have 22 counties that I serve in Iowa out of the 99 counties. And the mission of the RHS is to cultivate the workforce that will end HIV, STI, and hepatitis-related health disparities in Iowa. Yes, I said cultivate. We're Iowa. We cultivate, right? Okay, that was corny, and you said no. That jokes. But then initiative started in 2016 with the planning group, the HIV planning process. And we actually, to be honest, we thought we invented academic detailing because we'd never heard of NaRCAD, and we thought this was a great idea to do this work. And since there's only 5 of us in the state doing this work, it was really good to collaborate with others in the state, which you'll see in a few minutes. Some of you are familiar with what happened in Austin, Indiana. There was a huge outbreak of HIV. It was the worst drug-fueled HIV epidemic to hit America. Well, we use this as thinking in the future what we need to do and how we can prevent this from happening and how we can educate our communities. And so the CDC had come out with a vulnerability index for counties they thought might be at risk for this to happen, for an HIV hepatitis outbreak or opioid overdoses. In Iowa, we came up with our own vulnerability index so that we could plan and prevent in those communities. They really had to work on resources and share their resources and come together for that outbreak. And we figured that's what we would have to do if it happened to us as well. So here's Iowa's vulnerability index. We put the top 10 counties in here. So if you look at the green counties, those are the ones that were at risk for HIV and hepatitis C, based on social determinants of health, based on the number of opioid prescriptions, opioid overdoses, you know, the things. And then the ones highlighted in yellow were at risk for overdose. The ones in red, and also in those columns on the right-hand side, highlighted in red, those are at risk for both. So when we examined the disease states, we noticed that of the top 10 counties at risk for any of these, 6 were at risk for both the HIV, hepatitis outbreak, and overdose. So given all this information, we know that it would be really good to collaborate. And we're going to look at a couple more slides of some of the data that we looked at. And this was data of the percent of people newly diagnosed with HIV in 2021. And I apologize that it's gender binary data, but that's what we have from AIDSview for Iowa. And so just looking at that data, we were aware that the male transmission rates that year, 10% of them identified injection drug use. And an additional 9.2% identified male-to-male sexual contact and injection drug use. And then if you look at women who were diagnosed with HIV that year in Iowa, 15.4% indicated injection drug use. So we're just looking at this cross-sector data. And then one more look, and this is really small, and really I just want to highlight that we got this information from our state epidemiologist, and it boils down to 11% of the cases of newly diagnosed HIV in our state in 22 years were also co-infected with hepatitis. So it shows that there's that connection, and we really only were focusing on HIV, STI, and hepatitis, but just a tiny bit of substance use. That wasn't our big focus area. And another thing to note on that chart, you might see that standing out, is we think of baby boomers having hepatitis C because we were asking them for a long time to test. And you can see that out of the 276 individuals who were co-infected, 103 were baby boomers, which seems a little unreal. And we also had Hispanic, Latino, and Black African-American high numbers there, disproportionately impacted, like many of your areas. Okay, that's a look at the data that we always examine, and we know what we're looking at. And then we are going to think of what happened next. We have a colleague, Liz, who works in our bureau, the HIV Bureau, but also in the Bureau of Substance Use. One day she came to us and pointed out, guess what? There are other academic detailers in the state, and they are talking about some of the same issues you are. Well, we were pretty upset about that. It's really hard to get in with medical providers sometimes, isn't it? And we thought, oh, they're going to go in and they're going to get in there. And then next week, we're going to call those same providers and we'll say, we're going to come in and talk about HIV, intersection of hepatitis and drug use. And they're going to say, somebody was just here last week talking about that. And there we go, our chances and our opportunity. I mean, we're just venting, right? And we were just complaining. Finally, I said to our manager, can we just do this? Can we just talk to the managers of those two programs? And I'll show you what those programs were in the next slide. Can we just talk about this? And he said, yeah, that's a really good idea. So we got the managers together with the two of us and we talked about what is the role? What are you doing? And when did it start? And how can we help? And how can we support your program? So the lesson learned there is reach out. Build relationships, right? Don't just sit there and complain about it like we did for a while. So we did meet with them and we really determined that these new partners had a message that we could layer upon. And I love that. And so the couple of the partners had specific names. There was the State Opioid Response Team. Some of you may have them. They're through SAMHSA. And then the strategic initiatives to prevent drug overdose, some of the OD2 work through CDC. So those two entities were now doing academic detailing in the state. So you can see that there was a crossover, just like I showed you the disease state crossover. But then we realized that, and I put this together, we didn't have this in front of us, but I put this together for this presentation, thinking back, our expertise was education. We were facilitators, and our topics were sexual health, STIs, HIV, Hep C. Just a tiny bit of substance use comes in there, but that's not where we were going. And their expertise was substance use. And then our role was to engage communities to work together to prevent STIs and end HIV, eliminate Hep C. Their role was completely different. Their role was to describe the landscape or prevent or reduce substance use and overdoses. And then I thought of some harm reduction elements because we each had different harm reduction elements. And you can think of these that are on our side as harm reduction elements, right? Sexual health assessments, teaching providers how to conduct a sexual health assessment. Even we talk to mental health providers about how to conduct a sexual health assessment. And then how to offer PrEP to your patients. That's a harm reduction element. We have a condom distribution program. That's harm reduction. And then giving them resources for people living with HIV or people who used inject drugs so that they would know where to send their patients. And then filling any gaps in knowledge and supporting our providers for what their needs might be. And then when you look at their side, their harm reduction elements, some of them were a little the same, but they talked mostly about how to access and administer naloxone. We could do that too, but why do it if they're doing it? They talked a lot about reducing stigma. So do we. So we can overlap. We can layer our message with theirs and reinforce their messages as well. And then they were encouraging the use of the prescription monitoring program. That's not in our wheelhouse. And reduce prescription of opioids. And they do support their providers as well with any needs that they might have. That's part of academic detailing. So when we looked at that, we felt a little bit better about things that we could layer our message. So the lessons learned was reach out, work with them rather than work in silos and work together. And we could learn a lot from them. So we did attend some of their sessions and we conducted some co-presentations. They even have attended some NaRCAD presentations as well. So I'm going to tell you one great presentation that we did together. I was with one of the SOAR grantees, the SOR grantee, and I actually had been to a police chief and he said, "Oh, this is great information, but you should come to the 5-county training that we're having." And so I got on that list and I was given an hour to speak. I gave up 30 minutes to my SOAR grantee. Why not? We could layer our messages and we could reinforce and support each other's message. And so that was a really great way to work together. And that's just one example of the co-presentations that I did. And I've got a little bit of future work going on too. Some of the things that we're going to do together. I've already talked to people and I did do some mentoring as well. And I used the 80 tools that I had learned. You know, they didn't know how to get into providers. They started right when COVID began. They had a disadvantage. We already had some providers that we were working with, so we could do virtual. But they didn't know anybody yet. So they were trying to call providers. And so I talked to them, yeah, you don't call providers, you know, here's how to do it. So I gave them lots of ideas. And then I helped them identify some gaps that they might run into. What might the providers need and how they could be a support for those providers. And then I listened to their key messages. I wanted to hear what it is that they're saying so we would know how to layer our work or reinforce their statements, but also, you know, stay in our lane. We didn't need to talk about the same things they did. So then I would help them to present better also. Let's make this bulleted. Let's don't go on and on, right? And then handling objections, of course, we talked about that. I role played with them so that they could learn what the providers might say on the other side. And that is really all. We learned a lot from them and they learned a lot from us as well. And I think if there's an opportunity in your state to collaborate with somebody who's doing maybe cross-sector or some issue that's similar to yours, I invite you to think of ways that will improve outcomes and provide a greater sphere of influence in your work and consider mutually beneficial outcomes for a more robust response to your topic. And I thank NaRCAD for letting me have this space to talk about the wonderful program we're doing in Iowa. And I thank my colleagues, 1 online and 3 over there, for their support because it's a team effort. Thank you.
Thank you so much. Darla, we have a few minutes to let folks chat with you and ask questions. So we are going to take questions for the next 5 minutes or so, if you all be willing to circulate the mics. And if any questions are on the minds of folks at home live streaming, please do let us know. Mike, go right ahead.
Darla, that was wonderful. Thank you. I'm really interested if you could say a little more about we've talked about sustaining programs, how hard, we're always thinking about where's our next funding cycle going to come from? How are we going to sustain our program? And it can get people to be very narrowly focused in their lane. We have to do exactly what think about what's the funder going to say to us. You really took a much broader approach. And I'm curious, did you think about, or did the partners you were enlisting have to think about, how are the people we're answering to going to see this? Are they going to criticize us for, as you said, getting outside our lane? And will we put our funding at risk? What I'm looking for are lessons for how everybody can be willing to take a risk and maybe sort of manage that risk so that they're willing to leap in and be collaborative.
Yeah, I think that it was important for us to give up that competition and worried about duplication. And so talking with whoever you might collaborate with, talking it through and determining that you do each have a valuable message. You are each experts. And I feel like I was able to tell my providers, refer them to some of these folks for a deeper dive into substance use. When they ask me questions, I'd say, I think you should talk to this person. And they would do the same for us. And I think that's why the co-presentations, like I said, we didn't always do AD one-on-one, but I think the co-presentations were really good to show this. They're on this side, they do this work, we're on this side, and we're interested in disease states. And look at it comes together. There's an intersection. So I think that's good to show that and show them that you support each other.
And Darla, I'm curious, as you sort of went a little rogue, did your funders support that? Were they impressed by the outcomes? Like, sort of what was the reception of the way in which the path that you decided to go down as a team?
Yeah, and our manager was behind this to talk to the other folks and see what the other side were offering. And we still stayed in our lane and did our talk, and they did their talk, but it was okay to do co-presentations. We do co-presentations with our disease intervention specialists as well. It just works out. And so it's okay with our funding. Our funding says we have to talk about and try to end HIV. We're working to eliminate hepatitis C, right? And we're still doing that. We just had some partners to help out. We can't get to every county. It's really hard.
Looks like we have a question right here.
Hi, you piqued my interest when you mentioned about presenting to not the health department, the law enforcement agencies. Could you unpack that a little bit and explain exactly the connection you made there?
Yes, we are a little different. We don't just talk to medical providers and nurses. We do talk to mental health providers and substance use providers. And I do a lot with corrections officers and sheriffs, because they have inmates who might be at risk. Why not let them know about PrEP? Maybe they need to get on PrEP when they get out of there. Do they need a syphilis test? Have you talked to them about their sexual health? Have you offered them condoms when they leave there? They're in a really good position to help out some high-risk individuals sometimes. And also for us to be very non-judgmental and model language for them. Oh, I usually say this instead of that, I remember when people used to say clean and dirty, and now we're saying this. So it's a really good place for us. And it's okay. We have autonomy to work with. We're not just talking to anybody off the street. We have medical providers, nurses, mental health, substance abuse, and especially corrections. Those are especially the groups that we're working with because they have people at risk, and we can help them to help those people.
Thank you so much, Darla, and such a small but mighty program of 5 across such a large state. And you're looking at harm reduction on the actual, outcomes and patient outcomes. But it also sounds like you're looking at harm reduction vis-a-vis, helping clinicians use language that is, more supportive and humanistic, so that harm that comes from things like clean and dirty, which many folks may not realize has stigma attached to it and just are used to those, they used to be the words that were used, that's also reducing stigma, which can then make patients feel more comfortable asking for help. So that's lovely. And we'll ask you more questions at the end of this plenary.
And feel welcome to contact me at any time also. Thank you.
Give it up for Darla.
All right, we have another poll everywhere question we'd love to throw your way. So get out your cell phones. All right. In your opinion, what kind of support do patients with substance use disorder need most? It can be any substance. It can be a personal opinion, a professional opinion based on what you've seen. All right. So it looks like with the judgment piece, I'm going to take a gander at that we need less judgment. Housing and compassion, as you see with this word cloud, the bigger the word, the more people are saying that it's needed. So empathy is up there. Programs, transportation. Yes, sometimes we forget about the intersection of care and access. And I apologize for some words being cut off. So I just see the word mental. It's probably mental health. The word clouds only do one word at a time. I see the word understanding, resources, medication, access, acknowledgement. This is a beautiful word cloud. And these are the kinds of things that you all are doing, the sort of work to have this kind of impact and get folks closer to these things. So as you're continuing to fill these out, I'm just delighted to see all the colors and the words getting bigger. I am very excited to introduce our next speaker, Dr. Katarina Frank. She also has a PhD. She hails from Dublin, Ohio. She is here to speak about a special project that she did with Alosa Health. Alosa in the house. Where are you guys at? There you are. And Katarina worked on a project called HRAD, Harm Reduction Academic Detailing, that was funded by NACHO, the National Association for County and City Health Officials, as well as our next speaker also worked on that. And this project was something that we had the pleasure of being involved in, checking in monthly, seeing how things were going. There were cohorts across the country talking about connecting with law enforcement. We also had some cohorts that were trying out academic detailing directly to policymakers. They're looking at doing a future one where they're going to be detailing to construction workers. So really seeing the coolness, and Jerry, I hope you're proud of this communications approach and starting to look at adapting it to speak with all different kinds of audiences about what kind of care patients need. And harm reduction is just so much so on the rise. And I'm really excited that Katarina can talk about her cohort. So I'll turn it over to her. Katarina, come on up.
Thank you very much, Bevan, for the introduction. And so I will just continue. I have nothing to disclose. And kind of Bevan already mentioned some of the information. So this program with the abbreviation HRAD, which stands for Harm Reduction and Academic Detailing, was a pilot project funded by CDC and National Association of County and City Officials. The pilot project was done in Franklin County, Ohio, which is most populous county in Ohio. It's located right in the center of the state, and the capital city of Columbus is right in that county. The time frame for the project was January to October 2023. So we literally just concluded the project just a few days ago, last week, and still looking to officially close it. So it's very fresh for us. What were the requirements? So the requirement was to speak with 15 participants and have 3 visits one-on-one with each of them. We chose to speak to healthcare professionals in walk-in clinics, urgent care clinics, primary care offices, and federally qualified health centers. When it comes to the key components of the program, there was development of the resource guide and access to participants, which was kind of the key to be able to do the project, to be able to speak to people. I would like also to mention our cooperation with local partners. Our local partners for this project was Columbus Public Health Office and also a hospital council, which were working with us, and they were worked with us, our ideas very well, received the program very well, and were very helpful. Okay. So that was a slide from some other presentation. Not my fault. So understanding harm reduction. When you say the term harm reduction, everybody say, I understand what it is. You know, it's prevention of negative effects. When you go to healthcare providers and you tell them, you know, how do you understand the harm reduction? You know, they say, well, I understand it's something to prevent, but to go deeper, that was pretty unusual to discover that there isn't a whole lot of knowledge about harm reduction as like a global and big system of strategies which would reduce negative consequences. And that harm reduction also include the movement for social justice. And it talks about the rights of people who use drugs, that harm reduction is also being non-punitive, non-judgmental. And basically, harm reduction is also about a respect for people who use drugs. The abbreviation PWUD, that stands for people who use drugs. That's what harm reduction includes as well, to don't judge. People make decisions. There was a poll about it already. We all make a bad decision here and there. You know, is there somebody who wouldn't raise a hand if I ask, have you ever speeded? Probably not, right? So can somebody judge you for that, or me? Because I sure did. Yes, of course. So that's the other ways to look at what harm reduction is. A little bit about the material development. This pilot program was a little bit specific in its freedom. We had a freedom to build our own key messages. We built our material with the supporting wonderful hand of NaRCAD. And but there was the freedom, so we needed to develop all that. The one request which came from nature was to meet with people who are using drugs and people who are in active recovery. When I heard that, it was kind of like, I didn't know what to think about it, I'll be honest with you. Like, okay, well, if that is something what I need to do, I'm going to do that. So I used some of my connections. I went to some of the recovery clinics, spoke with patients in recovery clinic. They led me to people who actively using drugs, some of people they know, somebody in a family. And I concluded a bunch of interviews. The interesting thing was that what I discovered was that this was probably the best part of it. This is what I learned the most. This is how we were able to put the best messages which were representing the current drug landscape in Franklin County. This is how we were able to conclude the crucial context for the health behaviors and outcomes. This is where I learned that it is possible to build a relationship, trusting relationship with people who use drugs. And this is where I learned what people who use drugs are going through. That's where I learned about how long the history of mistreatment of people who use drugs is in the healthcare. Okay, did I? No, I did not. So what we developed were 4 key messages. This is the first key message. When I came for a first meeting with provider, I brought this message, printed out, we sat down and started talking. The opening session was started with a little bit of statistics and continued into explaining what exactly the opioid use disorder is. You might be surprised that a lot of MDs, DOs, NPs, and PAs are not familiar with abbreviation OUD or opioid use disorder. Then I quite often ask them at the beginning, what does the patient who has OUD looks like to you? What was the most common answer was, well, it's the disheveled person who comes hungry, dirty, and comes to my office. That's how they look. Well, over the progress of our meetings, we came to the answer that the person with OUD can look like me, can look like you. That's where we end up with these explanations. I went a little bit into science. I find this to be very helpful when I'm able to explain to providers or healthcare people working in a healthcare the biology of genes with the environment, how they together lead into the drug use. And then we go a little bit into pathophysiology and neurotransmitters and how the brain works and what's happened in there. And this way explain addiction. This is a very helpful way to start attacking the stigma, which is there. Yeah, I'll talk about it a little bit, but we already talk about it a lot today. Another part, and that's again something what I heard a few times already here today, is the correct language. This came with our first key message to explain to providers what is the wrong language and what is the right language, how to use it. And the last part of the first key message was talking about the most prevalent myth in the area. What they hear, what is the information shared in between, but unfortunately it's untrue information. Okay, second key message, I guess I have to speed up. Second key message was a lot, we still digged into the terminology, talking about tolerance, dependence, and opioid use disorder. But at this point, I started explaining to providers also how to diagnose opioid use disorder, because healthcare providers are in a unique place when they are the ones who can diagnose and treat. And treatment is a part of a harm reduction. The third key message was directly about what we have available for treatment of the opioid use disorder. It was very interesting, very well accepted by providers. They were glad to learn. And the fourth key message was about everything other harm reduction, from naloxone, how to talk to the family, how to introduce it, what are the other harm reduction strategies are, as you know, looking for infections, talking about the clean equipment, fentanyl strips, all the way to xylazine. Interesting thing, from 17 providers I was able to speak with, only one ever heard about xylazine.
You tell folks what that is. I don't know.
Xylazine? Xylazine is actually a medication which is only prescribed by veterinarians. It's a strong sedatives used for horses and cows. And this medication, as I read recently, was first used about 6 or 7 years ago in California, when people who use drugs discovered that mixed with other substances, it increases the high. At that time, it wasn't reported by California, and 5 years later, it showed up in Midwest, and I'm guessing in the rest of the United States. Xylazine is not an opioid, but it's very often mixed with fentanyl. And this way, naloxone or Narcan is recommended as a harm reduction tool. The specific of it is that with the xylazine, what is typical for us are skin lesions. Skin lesions which patients show up with and they're unexplained. And this might be the sign when they should ask about xylazine. So that's my pleasure. Another resource which we developed here, and this was strictly developed after my meetings with the people who use drugs and people in recovery. It's a plasticized card. I'll be happy to share, have a few samples. It has two sides. The red side is if you are not ready to stop using drugs, basically offers to people resources which they can find within county for where to find a free naloxone, fentanyl strips, clean equipment, even how not to use alone. The green side is if you're ready to go, if you are ready to talk about the drug use. And why did we think about it? So many people during my interviews were telling me, I would have started treatment a long time ago, but I didn't know what to do. I didn't know that I don't have a primary care provider. I didn't know that I can just walk in an addiction clinic, ask for a care. I didn't know what to do. So this was something what led us to develop this material. It is something what the public health office in Ohio is using and will be using hope in future. Another material very well received was the local resource guide. And this resource guide had all the information about inpatient, outpatient treatment, mental health professionals, and plus all the harm reduction where they can receive Narcan, fentanyl strips, and other material, but as well also it touched on those social determinants of health like housing, transportation, food, childcare, and so on. This came in a booklet and it was very well received and appreciated because the providers were keep saying, this is something what is fantastic. I'm going to have it. I can open it up. I can find, I know where to send my patients. With the program, what we developed or how we were surveying it was with two surveys for providers. The first one was before we started first session. Then there was the larger one that was after the third session. And I did survey after each meeting. So there were 5 surveys attached to every provider. So the concerns and barriers. What did I hear about? Stigma. We talked about it a lot, so I will continue to next one. Lack of education. That's probably part of why stigma's there. Lack of education definitely is a big part. Support and advisory system not established. So many times for this or any other programs, I'm listening about providers wanting some support system, somebody who they can call, they can text when they have those first 5 patients they treat for OUD. The request was ongoing and is ongoing. Legal landscape, well, that's a shaky one because what I learned, fentanyl strips in Ohio are paraphernalia with the quiet agreement from governor who says, but we're not going to prosecute anybody. Well, make your own opinion. Where would you go with that? Lack of support from healthcare systems. I spoke to providers who are telling me, yes, I would want to prescribe Suboxone. I want to treat people. I have patients who come to me that they want me to treat it because they don't want to travel to some other clinic, but my health system doesn't allow it. My health system doesn't want it. And then terminology. It was interesting for me to learn that EHR terminology is very stigmatizing. For example, Epic, when they do a drop down to diagnose a patient, offers words like drug abuser. And once they click it in there, it goes with the patient for good. So that was my findings. And academic detailing, impact of academic detailing, since this was harm reduction and academic detailing. Academic detailing is a fantastic way to approach sensitive topics. And again, we already spoke about that before. Providers are more open. We can build a relationship. We can talk one-on-one about something what's touchy. But what I think it wasn't mentioned yet was that it was really awesome to tell the personal stories. When I went to the providers and I took the stories I learned from people who use drugs and people in active recovery, when I brought these stories, it was very impactful. Bring a story. It will do the impact. They will remember better the detailer. They will remember what's going on. So, and I guess to make it shorter, I would very much, fulfilling this program, recommend academic detailing and being this way, how to approach these sensitive topics. When it comes to results of the HRAD, we completed 47 visits with 17 providers. And I'm happy to say that I have 3 emails that people from Nationwide Children's Hospital want to join program, which is over. So the interest was great. The providers reported increased knowledge. They appreciated the local resource guide. They learned how to diagnose opioid use disorder. And what would I recommend? I would recommend explaining more harm reduction and OUD terminology to providers, which can definitely lead to reducing stigma. I think there is extensive need for education and information delivery regarding strategies. I think there is a necessity to look at the legislative restrictions and a health system limitation. And this way kind of approach the stopping and lead to implementation of harm reduction. Thank you. And may I want one more thing, Devin?
Let's go right ahead.
Okay, I just wanted, since the program just finished, I would really like, because they're all here and we have a fantastic team in Alosa.
Throw your hands up.
And I would very much like to thank Alan Dansell, who is our Director of Clinical Material Development, who worked on these fantastic messages, which got me to the offices and made me to fulfill it. Mackenzie Rowe, she's there, is our program coordinator. She's just awesome. You know, every time you need something, everything, she was right there. And of course, Dan McMahon, that's the guy who's always there for us. And of course, you, NaRCAD, for all the support for the program. I really appreciate it.
Thank you. We really didn't do a lot, but we'll take it. Stay on up here. And that was nice. That was kind of like the Oscars, right? Like I couldn't have done this without Mackenzie. Okay, so what we would like to do is now open it up to some questions. Our live stream is a little on the sleepy afternoon side, but folks on live stream, if you have questions, do pop them into the chat box. And Katerina, I'm going to switch spots with you. All right. So questions, go right ahead. There you go.
There we are. This isn't so much of a question, but more so just wanted to make sure I heard you correctly. Did you say out of the 17 providers that you visited or that you detailed, that only one knew about xylazine?
Yes, that's correct. And being honest, this guy was a director of addiction services in Ohio State University. That tells you something.
So getting the information out there is all the more important for sure. I see a question from Elizabeth on live stream. She wants to know, how did you address the idea that harm reduction by providers is aiding and abetting addiction, which of course, as we know, is a stigma and a myth? Did that come up at all? Did folks think that harm reduction would be sort of enabling folks who use drugs to continue using?
Yeah, that definitely is a part of the stigma. That is why I always, with the thought that this may come up, started addressing and explaining the providers something, or started talking about the respect, started talking about how we all make bad decisions. Others might not be agreeable with them.
But do we really have a right to judge? And explaining to them that harm reduction is not just the way to treat people, it's the way how many times we get a patient or person who uses drugs to the part of the life where they might make the decision. We'll keep them safe and we'll keep them alive. And I think that's mostly resonated with the providers.
Thank you, Katerina. And I know you also mentioned the fact of reminding clinicians that this is a disease state, right? So this is a medical condition, which is always important to go back to the evidence. Vishal, you've got someone in the back.
Thanks for your presentation. I know you mentioned this was a pilot, so just wanted to hear more about what future plans you all have, and specifically because we've started to talk about this earlier where there's some opportunities for collaboration. So just wanted to hear more about what's in the future for y'all.
My understanding, this was a pilot project which was happening in 7 different states and in particular counties in a state. That's how most of the pilots are going. My understanding from those CDC and Nature pilot program is that once the first data from the pilot program are all collected, they get somehow, looked at and then further developed with the final goal to establish a program which will be a federal. So I cannot answer what exactly the plans for Nature and CDC will be regarding this, but that's how I understand the big picture. And that's how it went with the other pilot programs, which I did, that I see that the further steps are taken and hoping for the bright future of having a big program.
I know what the plans are. There's probably going to be more of this. So yeah, it's been great work by so many different cohorts across the nation. Great question, Carla. Thank you. We have time for one more question for Katerina, and then if there are any more, we can hang on to them for the group discussion. Anybody else? Live streamers? All right, let's give Katerina a hand. Thank you. All right, Vishal, come on up here and help me out with this. All right, this is all you.
All right, we're going to jump into another poll question. Go ahead, please text it to the number and let's see what answers we can get. Let's list one word to describe a positive impact of harm reduction. So this could be anything you can think of that really, there we go. It's got some coming in. Alive.
That's a pretty big one.
That's
Alive
a
is pretty
huge
big.
one. Seeing safety, survival, community engagement, it looks like. Seeing quite a few good ones.
Respect. Sorry, that's a little loud. Respect is a huge one. Definitely respecting respecting
Encouragement.
humanity. Yeah.
Yeah.
Yep.
Interventions, honesty. I like that there's pleasure on there too, because that often goes to show you can.
Right.
You know.
Supporting. So for instance, if you're doing harm reduction for, sexual health, you're also supporting that versus taking a sort of abstinence or a very black and white perspective.
I agree. It's very person first. It's
Yes.
fantastic.
All right.
A lot of
well,
great
as you guys
ones.
keep populating that, we will introduce our final presentation for the day. Thanks for sticking with us. And I'm sure you will enjoy this one as well.
We are super excited to have this next one. Dr. Leah Toby Moore, who has been a physical therapist in Arkansas, as well as with a focus on chronic pain management, has also worked a lot in clinician education and has some wonderful experiences to share with us today about physical therapy, pharmacy, and primary care. So without further ado, let's welcome Dr. Leah Toby Moore.
Hey y'all. Hey y'all. Oh, hear me now. Thank y'all for hanging out. I know it's been a long day and it's always a challenge to be the last speaker. So I'll try to make this as entertaining as I can. I'm not going to call the hogs or anything unless you want me to. Okay. So I am curious. Have y'all ever heard of a PT? I'm going to stay here. A PT doing academic detailing before? Raise your hand if you have. Yes, you were one of my trainers.
Okay, cool. So I hope to be able to kind of enlighten some of your perspectives today, and I'll give you a little bit of history as to how I began on this journey of chronic pain management and really in the world of academic detailing. I do not have any disclosures aside to say that I have a chronic pain condition. And when I started my journey, I thought, okay, well, this is really disheartening. You know, I'm a provider at a major medical institution in the capital city of Arkansas. And how in the world am I, as a provider myself, struggling with finding these resources and connecting with other folks that aren't just telling me, oh, you're a PT, you know what to do. I'm like, oh, okay, that's cool. But I can't do all of it by myself. So I will just start out by sharing a little bit of background information. I'm sure y'all have heard that being in the South, we struggle a lot with opioid prescribing and dispensing. We're in Arkansas, we're second to just Alabama for opioid prescribing. I'm looking at the chat and getting distracted. Yay, PT on the chat. So we do struggle a lot. It's not just about rurality, although that is a really big component. I know some of the folks that we have spoken to, they'll just say, well, we don't have PT in our county. We don't have an acupuncturist. Massage therapy? Oh, yeah, that's great, but we don't have that either. So a lot of our providers just simply say, we don't have another choice. And if they don't seek our care, maybe they've been, treated by the same primary care provider, APRN, for the last decade. If we don't give them their opioids, they're just going to turn someplace else. And so here's a little bit of our statistics. Since really the COVID pandemic, we've seen a 36% increase in opioid-related overdose deaths. And those aren't just prescriptions, as several people have mentioned during today's talks. A lot of them are synthetics, and it's not a problem that's going away. This is certainly not just, these aren't certainly folks that are just people that are struggling, that I think it was Dr. Katarina that was just mentioning. Some providers have kind of a jaded perception of what these folks look like, but a lot of them are successful. They're holding down jobs, and it's just an ever-growing problem. I'll jump into another statistic here. Overdose deaths involving methamphetamines and opioids have doubled. And in the South, y'all have probably seen in the news, there's always like meth house busts and things. So that is a very huge problem in Arkansas as well. And then I'll just say this, that we at the University of Arkansas for Medical Sciences, our AD program, we struggle a little bit because we don't have specific provider prescribing rates. That would be awesome. And I'm always jealous about listening to some of the VA cohorts that are in the room. I'm like, y'all have such awesome, rich data. That would be so great. We could target specific providers. Hot dog. That would be awesome. We can't do that. So what we do is we have to focus on what we do have, and that is dispensing rates. So the beginning of the program, what we started to do is we targeted counties that had the highest dispensing rates, and just hopefully, fingers crossed, we were able to touch some of those providers that were feeling like they were struggling in rural Arkansas, and maybe perhaps give them a few tools for their tool bags. But this is what our state looks like. These are our dispensing rates. So just to kind of give y'all a little bit of perspective, I've heard several people have like families in Northwest Arkansas, Fayetteville, Bentonville. That's where the University of Arkansas is. So that's in the very northwest and portion of the county. And Megan and I, who's here with me today, we are in Pulaski County. They're the kind of lightly shaded county in the middle. So we're doing pretty well as a whole in our county, but y'all can see several different areas that definitely struggle.
And I didn't mention this because I wanted to mention it now, but we are still verging on double the rate of the national rate. In Arkansas, we're about twice as much as we should be as far as opioid prescribing goes. So of course, if we're comparing county to county, interestingly enough, I'm going to jump back. Let's just look at Pulaski. It's kind of taupe here, white, and it's red here. So these are the all drug-related overdose deaths per 100,000 people. So it just kind of makes me scratch my head and go, okay, what are we missing here? How come in Pulaski County, we have lower dispensing rates, but yet we still are struggling with more overdose deaths. So as of 2022, we had about 500. And I'm sure as many of y'all probably struggle with this as well. The way the coroner codes the death can be a little bit, I'm going to just say sketchy. Because say if my uncle knows my friend who overdosed and I just say, oh, they're a really good church going family. And I throw in some family dynamics there. Perhaps they could code the death differently. So who knows? I'll just say that all data is not necessarily as it appears to be. So let's talk about the good stuff. Our academic detailing program, we just completed the same HRAD pilot as ALOSA did, and we were on several calls with them and several other cohorts with NaRCAD. But our primary goal was to increase primary care provider knowledge about multidisciplinary therapies, alternative therapies, and alternative meds as well. And then, when possible, reduce opioid prescribing. And then, of course, with the HRAD implementation, we wanted to be able to implement lots of harm reduction strategies like person-centered and person-first language across those rural primary care practices in Arkansas. And this is our team. Megan is here as well. She's our pharmacist on the team. I'm a PT. And then we also have Mohab Ali, who's not here with us today, but he's an MD. And he is now off of our team, I'm really sad to say, but he is working on his STEP exams and working on trying to get into a psychiatry residency. So we're proud of him for that. So here's a little bit about our evolution of our program. So our first campaign was before us, and this was in 2019, where we had one pharmacist, and she focused all 100% of her time on educating providers, again, focusing on counties that had the highest dispensing rates. She saw 103 providers. And if you notice, the response rate was pretty low at 30%. So when we came along together, we were like, how can we be as innovative as possible? And we came together synergistically as a multidisciplinary team with our mentor that started the very first funding, who's also a pharmacist. And we started to think about, okay, well, cool, we're a multidisciplinary team. How is that going to be perceived? And what can we do to start getting more folks on the calls with us? And mind you, this is during COVID. So we were already we felt like we were, starting with a shorter straw. But we started with 4 different modules, and those are, I know y'all call them campaigns too, but just semantics. But I'm happy to go over each of those. We started with opioid safety, benzodiazepines as being the second drug epidemic, preventing overdoses with naloxone, and then a program from the Institute for Healthcare Improvement called Age-Friendly Healthcare. And that is folded into chronic pain management of the older adult. So then in the beginning of 2022 through the end, we continued to offer those 4 modules, and we were able to see 65 providers. And I will say, not any of us do this full time. So we're on different grants, different programs. We all have clinical practices. So we spend anywhere from 8 to 16 hours a week together. And we were super pumped that we got an 84% response rate. So our marketing was helpful, our continuous outreach with providers. And then I think offering that CE was a huge carrot to be able to dangle. Then this year we started the HRAD program, and I'll read some of the fonts up here because I see they're small. So we continue to develop more materials, and we kept hearing from provider after provider, y'all, we just don't have time with patients, and we struggle with being able to change patients' behaviors. So again, it goes back to that comment. Well, if I don't prescribe them their opioids, they're just going to turn to other unsafe places or other providers that will give them their meds. So we started to look at more motivational interviewing, and I worked on a separate COVID-19 motivational interviewing program for veterans through the VA, and we put together a ton of MI skills to be able to give to providers, and they loved it, and we were so happy about it. Just felt like it was opening a door, giving them fresh ideas of understanding what stage of change patients are in, instead of just, leading the horse to water and expecting them to drink. Or in my practice, you just tell patients, well, your knee hurts. Well, don't do that. If it hurts to do this, don't do that. Well, that doesn't necessarily change, what they have to do for life, right? So we wanted to give them more tools for their tool bag. Then we wanted to continuously innovate the program, and we started to think, okay, well, how can we get younger students involved in academic detailing? And we had a 10-week PharmD research elective. And so we had a young man who helped us develop more materials. He did the NaRCAD training. He was super helpful. And he also developed a MAUD module for us, which will, we can certainly get into that more later, but it's going to be used through some of our Project Echo series. And actually, Megan's already presented it with really good feedback. And so through this program, through the whole HRAD program in 2023, we started to consider special populations. I mentioned those who have chronic pain, and I mentioned older adults with age-friendly healthcare. And then we also, through the Pulaski County Jail System, we sort of did like a peer-to-peer, what's the word? Anywho, sort of like a mentorship. Thank you. Yes. But we just wanted to listen to them, and we started, using their opinions to be able to formulate different key messages along with NACHO's help and NaRCAD's help. And then from November of this year, so just started through 2027, we are really thankful to have been given a SAMHSA grant. And it's going to be able to continue us doing lots of naloxone training. So it's called ANET, or Arkansas Naloxone Education Training Program. And it's going to be using Train the Trainer. And so we're really pumped to be able to partner with MIMS and different emergency services in Arkansas, and lots of other community programs as well. And we also have received additional grant funding through this work, and we're very pumped about that as well. Lots of evidence-based treatment for opioid and stimulant use disorder, which is very much needed. And that is also through SAMHSA or Region 6 ROTA. And we're doing lots of technical assistance, sharing echoes, and all sorts of good things like that. So I'll share briefly a little bit about our evaluation through the HRAD program. So in the red there, that's always great to see. Our N here was 48. They could choose more than one option. This is changed to clinical practice. So the red is validated their current practice. Cool. You already knew about how to, reduce benzodiazepines, opioid safety. You're already prescribing naloxone or discussing naloxone with your patients. And I should say that's orange, sorry. The red is what's really exciting. They created revised protocols. And then the yellow is they wanted to be able to change the current management and treatment of patients. And then more provider level data, like I said, N of 48 on the last slide, because they could select more than one. So we had 45 thus far complete their CE evaluations. And the yellow is always good to see. That's the big yes. We improve knowledge. We hopefully are changing patient outcomes in the positive, improving provider performance, and improving their competence. And that was on there twice. So just a few references, and I'll leave you with this. If you had just one thing that you wanted to take away from the talk today that I'm giving, is how you could incorporate some form of PT or some form of movement-based therapies in the discussions that you're having with folks who might need more information about chronic pain management. My two favorite phrases: motion is lotion. Y'all ever heard that? Yeah. Okay. And movement is medicine. So those are great things to be able to incorporate with your clinical practices, and then also hopefully those that you're training with academic detailing. Thank y'all so much.
Thank you, Leah.
All right. Such a great group. So we can have time for questions for Leah, but I'm also going to invite up our first two speakers. So get on up here. I'm not getting away yet, Katarina. And Darla, are you in the house? Yes. Okay. So come on up. You all can share a mic. First of all, any questions specifically for, apologies there, for Leah? And again, having two folks from the HRAD group is just really lovely because then you can also see the diversity with the cohorts. Mike, over to you.
Sure. Thanks, Leah. That was great. The thinking about is your detailing as a physical therapist and the unique advantages for you in that role. How do you talk, one of the challenges in harm reduction, kind of wearing my primary care doctor hat now, when I try to engage patients with physical therapy who maybe, they've, for whatever reason, have taken away the message, why don't, I'd like to be prescribed a medication instead. How do you prepare the clinicians you're talking to for that sort of skepticism, get them ready to be good promoters of physical therapy, besides your two buzz phrases, which are great, but besides the two, motion is lotion and movement is medicine, right?
Yes, motion is lotion. Love it.
But besides those two, how else do you get at that barrier that might well come up?
So I think it's important to say that every patient is going to have a different experience. Just like all of us have different personalities. I've not clicked with every patient that I've ever worked with, and that's completely normal. I mean, I don't know how I would be able to completely click with every single patient that I've ever worked with. I certainly try. But with the clinicians that we oftentimes are talking to, it's really all about meeting patients where they are, just like with every other conversation that you're having. I think it's always nice to ask the clinicians to then ask their patients, were you working in a group setting with your PT? If it's been a bad experience, which it's usually yes, because most people will have pretty positive experiences if they're able to work one-on-one with a therapist. But say on the flip side of that coin, if a clinician just isn't normally, referring to PT or any type of movement-based therapy, it's not just PT, it's chiropractic care. It could be acupuncture. It could be a personal trainer. I think it's just really great to understand where that patient is with their decision-making. Are they ready to jump into a program, or should we just discuss what hasn't worked for them in the past, what has worked for them, just to better gauge where they are in their decision-making?
Thank you, Leah. Folks in the live stream, please go ahead and pass your questions on up so I can read them to these folks. Narissa, question from you.
Thank you. Just kind of bouncing off of Mike's question, in terms of some of the barriers as well, how would you address with the clinicians the limited resources? So one of the things for us in Illinois is that there's a whole rural section where the closest physical therapist may be 30, 40 miles away.
That's a great question. Thank you. And I was just telling Megan before I came up here, I hope I remember to say this, and I didn't. So you reminded me. We've actually put together a lot of supplemental materials for our clinicians that are in the very rural areas, that they might actually be the mental health provider, the physio, the PCP in the county. And what we did is we took several of the most common pain conditions, being like osteoarthritis, headache, low back pain, cervical pain is also filtered in there, and fibromyalgia. And we gave them evidence, and it's in a lovely chart of how to start to suggest what they could be doing as far as evidence-based therapies. And it kind of just gives them talking points. So those also can go along with having good conversations with patients. And, we know that the rurality is not going to be a problem that's going to be fixed anytime soon.
but at least they could have what's most evidence-based so they can suggest those therapies or medications for some of the most chronic pain conditions that are common.
Thank you, Leah. Other questions? Yes, up front here. Vishal, can you do a little run up front there? Do a little jog. Thank you.
Question for, I guess, the entire, like all three of you, more just around patients or, patients with opioid use disorder, more around their environmental factors that may have led them to those situations. The only reason I ask, I work as an academic detailer, but I also work as a community pharmacist in Toronto. And a lot of my patients that have opioid use disorder, there aren't the typical patients you think of. And what I mean by that is they're working professionals, they have families, they have jobs, secure income. I just wonder if that information gets out to providers, that our typical lens or what we think of a patient with opioid use disorder, it may not always be that type of patient or that thinking, right?
Can I ask you to clarify the question in that?
Yeah.
So it sounds like you're saying that you see a lot of patients that don't fit your own, there is a stereotype, unfortunately, that's not always accurate. And then it seems like you want to bounce a specific question off of them.
Yeah, like I just wonder if that gets through in some of the detailing visits, or if there's research or there's interest in looking at some of those patient-specific factors at all in some of the work that you've done.
So I'm going to throw that to Katerina first. So Katerina, does it come across that there's conversations about, kind of destigmatizing or breaking down, what does a quote typical patient with OUD sort of look like or present, which in and of itself is just such a curious thing that we ourselves must all have some sort of sense of that's not completely accurate. But did conversations like that come up? Were you able to break through to having conversations like that with your providers?
Yes, we have the conversation actually quite often. And as I mentioned in my presentation, when I discovered that providers imagined that patient with OUD looking very different. But what you mentioned is exactly what I do in detailing, kind of beginning of the discussion. I tell the providers, about almost 70% of the patients with undiagnosed OUD have a college degree, have a full-time job, have a family. They might be your patients who come here and you don't know. Part of our campaign for other programs is to ask providers to ask every single adult patient once a year the question, have you used opioid medication for non-medical reasons or illicit drugs? That would be part of the physical when they ask about smoking, about alcohol. Ask that question, as does everybody. And this will kind of open the can of worms, and providers start using it and they discover that, oh my gosh, I have a patient with OUD. This patient, they want, and they never talk to me. And why they never talk to me? Because I never asked. When I ask, then that's when when the subject or the topic starts to be discussed. So we do, it's a big part of our projects, and I think it has excellent results.
Thank you, Katerina. And I'd love to pass it over to Darla. Darla, just sort of a spin on this question for you, and then we'll see if anybody else has questions. In terms of having conversations with clinicians, what do you find comes up related to harm reduction that may have a lens around stigma or something you need to kind of guide back to a bit more evidence, the way that Katerina said, 70% of these folks actually aren't fitting this makeup that you think that they are?
We in general see rural providers who say we don't have it in this area. And again, it's because they haven't been asking or taking the time to talk to their patients either. But they have a lot of stigma and a lot of negative language around it as well. And even when I talk to sheriff's departments, I hear, they're burnout, right? And you hear some of those conversations. And so I don't really go in to talk about what they do look like or how, but I ask them to screen for everything, right? If you can't find Hep C unless you're talking about injection drug use, you're not going to find HIV unless you're asking somebody. And so it's just a matter of getting them, encouraging them to, some providers will screen for syphilis when they're doing an HIV test or vice versa. Some providers will ask their patients about injection drug use. So I like to model that third person language.
That's excellent. And it sounds so Captain Obvious, but again, it is, we don't know unless we ask. And to normalize for clinicians that, yes, it's uncomfortable, but not asking is going to accomplish very little. We have a question up here, I believe. Carrie Meyer.
Hi, everyone. I love all of your presentations. I just wanted to ask, so the state of Maryland has decriminalized and legalized in some capacity cannabis and things like that. And I meet with pediatricians on the regular because it's very popular among the teen. Are there any tactics that you are using to address those teen cultures?
Oh, I worked in one of the pilot programs about adverse childhood experiences, spoke with pediatric providers, but this area wasn't something they mention it. We talked about from the medical standpoint about the cannabis, but didn't go any deeper into it. Most of our programs are for adults in an area of opioid prescribing.
I won't put anyone on the spot, but this could be a reception conversation. Does anyone feel like they have any insights about detailing related to cannabis that Carrie could chat with during the reception? Zach, maybe a little bit? What's that? Okay. Okay, great. All right, any other questions here? Anyone else? All right, we'll give it up for these three ladies. Thank you so much. All right. So a couple things, I promise we won't keep you long. So maybe you want to stretch. Maybe you want to, hoping you'll come to the reception. But thank you for a terrific day one. And, one thing I really want to bring up too is normalizing conversations around our own implicit bias. So one thing I want to say is, sadly, it's been 5 years since I've been to a NaRCAD in-person conference. And there was a presentation that really struck me. We had a presenter who was giving just very enthusiastic, data-rich presentation on use disorder and talking about demystifying, who we think the character of a person who uses drugs may look like. And she gave this elaborate presentation about an anonymized woman in a case study. And she described it and talked about how the woman went to the ER and was mistreated, treated quite inhumanely, talked about as though she wasn't there, clinicians calling her a junkie to one another, and how upsetting that was. And then at the end of the presentation, she said, this person, you remember this, Jerry, this woman eventually was able to seek care, but it was an uphill battle. She didn't have transportation, et cetera, et cetera. At the end, she said that she had gone into treatment and still struggled, but actually became a social worker to help folks and talk to patients who had use disorder and had just had twin boys. So everyone's clapping. She switches the slide forward and she says, and these are my twin boys. Just kind of knocking us on our butts. It was her, right? And so I sat there shocked and also feeling like, wow, I was picturing somebody else. And so normalizing these conversations is so important. And again, recognizing the ways in which stigma is imposed on us societally through storytelling, through these different categorizations of people. And that once we understand the way that our minds work, we can better empathize with clinicians who may be using the wrong language, who may have had, as Katerina mentioned, experiences that are very specific, heightened, in a very specific context. So again, just all of these conversations today have just been such food for thought. So we hope you will chew on that a little bit more, maybe with some of what my mother-in-law calls hors d'oeuvres, Hoover Doovers. So if you want to come get some Hoover Doovers and some cocktails or some tea and other non-alcoholic beverages, please do join us at the reception. Vishal and I are going to talk about what's cooking tomorrow. We're going to breeze through it real quick. So why don't we talk about, Vishal, what's happening in the morning tomorrow?
Excited. It's going to be such a fun morning. We're going to get some networking. We're going to renew our passion for detailing. We're going to have an amazing kickoff on why detailers are irreplaceable. As Beyonce would say, we're irreplaceable. From there, we'll be going to Dr. Jerry Irvin's amazing annual AD talk on AI, artificial versus human intelligence, and the future of detailing. Really cool stuff. From there, we'll get into our break. And from there, we have some fantastic breakout sessions planned that you're not going to want to miss on taking AD to the next level. And then from there, we'll get a little lunch.
In the afternoon, we're going to do what we call a roundtable. Throw your hands up if you've been to one of our virtual roundtables. Yes? Okay, well, we're going to try to do it in person. There will be markers. There will be colorful Post-its. You have an option to be a little more introverted and doodle in the corner if you need to. But we're going to try to create our own programs. We're going to take an afternoon break. You're going to get to see some snapshots of what we used to call our yearbook presentations from some folks in this audience. And then we have a special surprise launch of something tomorrow that may be more exciting for me and our team, but hopefully exciting for you, of some new tools. And then we will wrap up, get you on your planes, or for those of you who are enjoying Boston, get you outside. So want to say thank you so much. There is 20 minutes between now and the reception. For those of you who will not be joining the reception, we will miss you. But for all of you, if you could please, we did build time into this session so you can do your evaluation. It takes less than 5 minutes and it gives us critical feedback about what we're getting right, where we might be missing the mark. Oh, I just remembered something. Somebody handed me some jewelry that fell on the ground. Is someone missing a pearl bracelet? Come on down. No, just kidding. You can wait. I'll bring it to you. So please do take a minute to fill out our evals. So you can win $250 if you throw your name in at the end. If you want to be anonymous, you just win the equivalent of $250 of feeling good for supporting us and telling us how we're doing. There will be a raffle and we will announce it in the week to come. You can either go to narcad.org/eval, or you can do what some of you are already doing and grab the QR code up here. So thank you again. Chat amongst yourselves. We'll see you at the reception in the St. James room. Everything is free and it's going to be cute and fun before you go out and wreak havoc on the town or go to sleep. I see you yawning over there. No, don't be. I'm going to go to sleep too. Don't be sad. All right. Thank you guys so much. And we will see you tomorrow morning. Bye.
Thanks, everybody.